think he got the wrong link, so that he can also join using the personal link, so we can see him on the panelists.
Yeah, we're still working on that. I think if he's in the general audience link, which I'm not sure how, we'll promote him as soon as the audience is opened. We have received his slides, so that's good.
Okay, all right. I think he's going to join soon.
All right.
Hey, is that good? I'm testing my sound. Can you confirm you can hear me?
Yes, Nick. Perfect.
So hi, Dicky. Good morning. Can you hear me?
Yes, I can hear loud and clear, Richard. Thank you very much.
Okay, now it's okay. Okay, great.
Good morning. Can you hear me? If you can hear me, wave.
I can.
Okay. Can I get my documents? Thanks. We're ready to start. Are we ready to start?
Yeah, I think we are ready with the panel session 1.
Okay. I can't. Okay, I'm going to just open up the session. So
okay.
good morning, good afternoon. I don't think I can say good evening to everybody, but we are very happy to have you here. This is day 2 of our framework for a equitable allocation of vaccines, and today we're going to talk about the country readiness for the deployment of COVID-19 vaccines. Yesterday we had a wonderful opening session, and what we heard about is that essentially Africa is on our own, and we need to make sure that we organize within the continent to ensure that we have the appropriate number of vaccines. We also heard that it was very important that we support our governments by making sure that there are public-private partnerships that will help us acquire vaccines at the volume that we need and ensure with the distribution as well as the logistics of it. We heard also that health is in Africa is a global public good, and we all need to be in alignment about this. We also heard that speed is of the essence. You know, we need to urgently acquire the vaccine and make sure that we are able to deploy it in a timeliest fashion. And I think it's a very good now to move on to more of the other aspects. I see Dr. John is here with me. I don't know if you want to say anything, John, before I introduce our moderator. Would you like to say a few words?
No, I mean, you summarize it so well, Glenda, just to say.
You're on mute or you're
Richard.
silent or they've done something to you.
We were able to hear John, Glenda. So maybe there's something on
Dr. John,
your
do you
end.
want to say anything?
Yeah. Can you hear me?
I can hear you loud and clear, John, so continue.
Okay, good. I think, Glenda, you summarized it well. And Richard, good to see you. I will just, I will let Glenda run with it, or Richard. Over to you.
Thank you. So I'm going to introduce our moderator, and Dr. Richard Mahigo. He is the Program Area Manager for Immunization and Vaccine Development for WHO Regional Office. So he's a very important person, and he's going to tell us exactly how to do this. So I'm going to leave the session to you, and thank you so much for agreeing to be with us today.
Yeah, thank you very much, Professor Gray, and thanks, Dr. Kingason John, for the invitation. We have a terrific session today. I think yesterday, as Linda said, at the opening of the conference itself, I think we have fantastic panelists who take us through some of the challenges that the region is facing. But I think what it was also very important, they brought up some of the solution that the continent could look at moving forward. And one of the really the issue that was raised, I think there was a lot of discussion about access to the vaccine, but I think many of the high-level panelists yesterday insisted on the fact that we need absolutely our country to get ready for deployment of the vaccine. So the third session this morning or afternoon will really be dedicated for country readiness for the deployment of COVID-19 vaccine. We have three very terrific panelists. I will start by Professor Gregory Husser, that many know very well. He's an infectious disease specialist with a focus on vaccinology. He runs and is the director for Vaccines for Africa initiative, which is located at the University of Cape Town. And he's currently a member of the South Africa Ministerial Advisory Committee on COVID-19. So Professor Gregory will take us through the lesson learned from past vaccination efforts. Yesterday, we heard the challenges that the continent is going to face. We have never been in a situation like this. I think, John, you mentioned yesterday how challenging it will be to immunize hundreds of millions at once. And this session this afternoon will meant to see how our country can be supported to take us through. So I'll be introducing the different panelists as they are going to make their presentation. So I will start by Professor Gregory to ask him maybe to go ahead and share his presentation to maximize the benefits of your discussion. I would kindly request you to keep your presentation to the 10 minutes so that we can have enough time at the end of the presentations to have the discussion, but also probably to accommodate some questions from the audience. So Professor Greg, over to you.
Thank you, Chair. Can you see my slides? All right, I'll start then. So thanks to the organizers for inviting me to participate in this virtual meeting. I will briefly discuss some challenges and lessons learned from 4 specific past strategies, vaccination strategies. The first one is the 2009 pandemic flu. The second one is the MENA introduction in Mali in 2010. Then talk very briefly about Ebola conflict and vaccine effectiveness. And then lastly, end off by commenting on new EPI introductions in low middle income countries. WHO declared the 2009 pandemic, flu pandemic, on the 10th of June. And on the right-hand slide, you can see that most countries in Africa reported cases, but only about a dozen countries reported deaths, which may be true, but it's probably a reflection of the problem of mortality surveillance and thus under-reporting. WHO supported the rollout of vaccines for low middle income countries. Vaccines became available in September 2009. And as you'll see on the slide on the left-hand side, of the 19 million plus doses delivered to 24 countries that reported their vaccination activities to WHO, only 12.2 million doses were utilized. That's only 64%. And population coverage in these countries varied quite dramatically, and with a median coverage of about 4%. But more importantly, on the right-hand side of the slide, you can see that the vaccines were only delivered and distributed after the peak flu transmission period in the region and more than 6 months after vaccines were developed. When you look at uptake of vaccination by people, this is just a paper published in 2012, looking at healthcare worker personnel uptake. And you can see it ranged very low from 12.7% in Turkey to about 60% in the USA and up to about 90+% in Korea. And I've listed the factors reported to positively influence healthcare workers' uptake, and they're listed on the slide, and they include access to past vaccination, trust in vaccine safety, and perceived importance of vaccination. And then similarly, with respect to community uptake of the 2009 pandemic vaccine, you can see it ranged from a very low 8% in Germany to 20% in the USA and up to 67% in Australia. And again, I've listed some of the predictors of the uptake, which included having a primary care provider recommending pandemic vaccine and perceived severity of H1N1 disease and age specifically, with older individuals more likely to be vaccinated. Just briefly talking about the successful introduction of MenA vaccine into Mali in 2010. And Mali successfully vaccinated over 10 million people between the ages of 1 and 29 at health facilities and in the community, both urban and rural areas. And important to note, there were a number of positive effects as well as negative effects. And importantly, the positive effects of the new vaccine introduction on routine EPI included improved governance and collaboration, better communication and social mobilization among stakeholders, and better surveillance and provider skill strengthening, especially those relevant to EPI. But important to note that there were some negative effects identified, and these include the fact that routine immunization services suffered, and to a lesser extent, other services like antenatal care. When we talk about Ebola vaccine, and this is an interesting paper where the researchers trace the occurrence of Ebola in relation to conflict situations in the DRC. And their results suggest that declining incidence was repeatedly reversed by conflict events. And although vaccination has contributed to the decline in incidence, they did a modeling exercise that showed that these disruptive events reduced the population level effectiveness by 43% overall. I also want to remind you that at the same time, and this may be an unintended consequence of both the conflict as well as the Ebola outbreak, was the fact that there was a major outbreak of measles in the DRC in 2019 with over 300,000 cases and over 6,000 deaths. And then lastly, just to look at a brief look at new vaccine introduction into EPI. And this is the case of pneumococcal conjugate vaccine. A pneumococcal conjugate vaccine was first introduced in the USA in 2000. And within 10 years, as you can see on the slide on the left-hand side, in 2010, vaccine coverage in high-income countries was of the order of about 60%, compared to low and middle-income countries where the coverage was less than 5%. And it took another 5-6 years before vaccine coverage increased in low middle-income countries of the same magnitude. And a lot of this was as a consequence of the support from Gavi. However, you can see that middle-income countries were lagging behind significantly at about 20% in 2014. And this was probably because all middle-income countries are self-financing with respect to their vaccines. The slide on the right, unfortunately, shows that there's still some countries in Africa that have not yet introduced pneumococcal conjugate vaccines. So what are some of the lessons learned from this brief overview of some examples? Firstly, countries in Africa consistently lag behind in accessing new vaccines. The cost of vaccines have been a major driver for delay in new EPI vaccine introduction. And there's no doubt that we need to advocate for early availability and distribution of vaccines in the Africa region. We know that generally speaking, conflict and humanitarian crises, and we know Africa have over 100 such of these crises every year, they have a negative impact on vaccine coverage and can lead to a resurgence of vaccine preventable diseases. And I think it's important to note that whatever we do in the future with respect to COVID vaccines and the rollout of COVID vaccines, we should not compromise our expanded program on immunization. And that there is clearly a need for collaboration between partners like WHO, Gavi, African CDC, who will need to work closely with countries to plan for rapid national deployment of vaccines. Just very briefly, strategies to promote coverage. Coverage was generally low during the 2009 flu pandemic, and there are probably a whole list of reasons for that. I think importantly, we need to develop peer communication and advocacy tools moving forward. And we need to create a communication link between public health officials and agencies that treat vulnerable populations at risk. And that we need to partner with CBOs, that's community-based organizations, non-governmental organizations, and faith-based organizations that deliver services to underserved populations and work with them to identify individuals and groups who traditionally lack access to healthcare. And then just lastly, just to remind ourselves that we should look at the future COVID plans in Africa. We should look at this as a way to strengthen our healthcare services in generally. We need to establish, and many countries already have good surveillance for COVID disease. We need to ensure optimal surveillance of adverse events following immunization so that we can track the safety of our COVID vaccines that we use. Essentially and importantly, we have to optimize the training of our healthcare workers who will be involved in vaccination. We need to ensure rapid access and delivery of vaccines. And we need to develop systems for rapid assessment of vaccine effectiveness, and maybe do this in selected countries in Africa that can inform other countries in the region. And then again, to emphasize, and this comes through with all the examples in the past, that you need to have an appropriate communication and advocacy strategy. And I'm sure this will be discussed later as well. And then just to end off with two quotes from a Spanish philosopher, George Santayana in 1905. Those who cannot remember the past are condemned to repeat them. And then from our own Nelson Mandela in 2001, it always seems impossible until it's done. Chair, thanks very much. I think I've stuck to my time.
Excellent, excellent. Thank you very much, Professor Greg. Like the two quotes that you have just concluded your presentation with, I think they are going to inspire us when we'll open the discussion. The fact that you started your presentation with the H1N1 experience, pandemic experience, I think it's quite critical. And Yesterday, this was really discussed. We don't want this to repeat again, Africa being lagging behind. So terrific presentation. I'm sure we're going to have a very good discussion on that. So our second presenter, I would like to call upon Professor Bartolomeo Dickey Akanmori. Professor Dickey worked at the regional office for WHO in the African region as a regional advisor in charge of vaccine regulation. Professor Dickey has been, for the last decade, supporting countries in managing the preparedness for vaccine regulation in the African region, working with partners to build the capacity of regulatory authorities. And I think that's it will be quite important that we hear from you, Dickey, how countries are going to be prepared, not only to provide the right approval for registration of COVID-19 vaccines that are new products that are going to be most of the time registered in an emergency situation. So Dickey, you have 10 minutes and you can share the slide from your end. Over to you, Dickey.
Thank you very much, Richard. Thank you for those very kind words. I did send the slides over. I believe, is it possible for them to be shared from your end?
Yes, we're going to kindly ask Sergut to help with sharing the slides.
Yes, but at the same time, I believe I can even start speaking. I just want to
no, the slides are on, Dickey. You can go ahead.
Yeah, thank you very much, Richard. And thanks to Dr. John Nkengasong, the Director of Africa CDC, for inviting us and giving us opportunity to be part of this panel and the discussions. These, as has already been said and stemming from yesterday, are very critical discussions because they would help us to do what needs to be done. And I just wanted to say that, you know, the region as a whole has a great depth of experience. And I think Greg mentioned this in addressing emergencies. It's not the first time we've been through emergencies, and usually it's an outbreak of a disease which becomes an epidemic. And then, you know, we have to address all aspects of this response, including product development. So I'm going to focus on what needs to be done. And the first slide, I think we need the next slide, please. Next slide. Thank you. Great. So I think we know what has to be done, and I'm going straight to the point. We have to slow down and ultimately address this pandemic, because we cannot go on like this. All the other measures that are in place have their own limitations. And despite the vigorous implementation of these, we still are in a pandemic. We still have a threat to life, and we need to address this. And to do this, what do we need? We need to ensure that we have vaccines made available as quickly as possible to countries. And the first thing is, I've mentioned here, is the need for a pathway. And so WHO has put in place a regulatory assessment and approval mechanism based on the emergency use listing. This is the first important point I want to make. The second thing is that assessors are coming from the same national regulatory authorities of all the different countries in the world. And it includes regulators from our region who have also contributed assessors who are currently taking part in the process from Ethiopia, from Ghana, from South Africa, and from Tanzania. The other thing is there is a mechanism being put in place which would allow for other regulatory authorities to use these outcomes, to use the assessments and the outcomes of these assessments to carry out their own regulatory work in a very timely manner. The next slide, please. Now, I just want to go into more details and to explain what exactly we mean. So what we have done is to develop, working with all the regulatory authorities under the African Vaccine Regulatory Forum, which represents the regulators of our continent, which also brings in all the regional economic communities who are doing a fantastic job of harmonizing their processes and procedures under each of the regs. We have tried to come up with this strategy, which has been endorsed by the AVAREF Steering Committee, which has also been taken to the African Medicines Regulatory Harmonization Steering Committee for endorsement. So first of all, ensuring that we are all aligned on one regulatory pathway, which we believe would work, and based also on experience from other diseases such as Ebola, where we had to go through a similar process. Now, participation of national regulatory authorities is crucial. And this, as I said, already we have got African countries taking part in the global process. But that's not the end of it. We also need to have regulators who are not participating in this process receive the same information and be able to do their own regulatory evaluations, but within a time limit. And here we're proposing 14 days is what was endorsed to enable them to do this. The next slide, please. Thank you. And it also means that we have to use not just a risk-based approach to the work that is being done, where data is reviewed as is made available and the risk and benefits assessed at different time points, ensuring that the process continues and that the manufacturers have a responsibility to provide data as soon as it's made available. If the data alters the risk-benefit ratio, this should be determined by the regulators and a regulatory action taken. But secondly, there's also the second principle of regulatory reliance, because what we want to do is to optimize the timelines, make sure we do not waste time, delay, or create any barriers to regulatory approvals. Hence, regulatory reliance, where countries would rely on the work of other regulators and on the basis of that, make their decisions. This is not a new practice. This occurs in regulatory work throughout the world and has been in practice for many years and has been used for many vaccines that we use in our region. The other point I want to make is the collaboration, and this is where joint reviews come in, where you gather countries, and this is already happening anyway at the level of the regs, because the regs come together and approve products for the group of countries that they work for. So it's the similar principle that we are advocating for. And the timelines absolutely are essential, are crucial for us arriving at a point where vaccines are not delayed, either shipment-wise or that they cannot be allocated because a country has not approved that vaccine type. Next slide, please. Thank you very much. And so we expect that COVID-19 vaccines, which are listed on the emergency use listing by WHO, after a thorough assessment, would receive approval by countries in the shortest time possible. Import permits will be issued, because that's also a critical piece of the whole process of access. You can do all the excellent work as a regulatory authority, but if at the end of it, the permits are not issued in time for the vaccines to be imported, we can have some difficulties. Right now, Ebola vaccines against Ebola have been approved, some pre-qualified, but not all countries have been able to actually do the final piece of issuing and authorization for these vaccines to be used in the countries. Next slide, please. Again, just to emphasize that the AVRF, WHO AVRF Secretariat will and continues to provide all the support to countries. Now, the countries, the regulators will do their work, but we as WHO are ensuring that information is made available as quickly as possible to regulators. Because we know that apart from the COVAX facility, and apart from vaccines going to WHO EUL, there will be vaccines coming in through other means. And here is where it's important for us to have a tripartite task team involving Africa CDC, AUDA, NEPAD, and WHO to ensure that we have some regulatory intelligence system in place, passing on information to countries, ensuring that they receive information about products that have gone through assessment, because we know, because the regulatory authorities, the UK, the US FDA, EMA are sharing information with WHO regularly. So that's also an important point to mention here. And to indicate that countries will have to identify and experts, and to set up a focal point for each regulatory authority responsible for these vaccines, including pharmacovigilance. The next slide, please. And I think I want to bring this to a close. I don't need to actually go through the rest of the slides. I just want to point out that in doing this, it's important that regulatory authorities ensure that they are ready, and we are tracking their readiness, ensuring that countries have first an expedited review procedure, one that addresses emergencies in place, and where they don't, we ask them to look at their regulatory framework and ensure that this regulatory framework can address this. We have done it before in the past with RTSS, a vaccine which was not licensed in the normal way, but they looked at their framework and they were able to find a process for approving the use of RTSS, the only malaria vaccine which is currently in implementation in 4 countries, in 3 countries in the region. So we want to make sure they have this in place, and we're giving them all the support to exploit this and put it in place. But I think in the longer term, what African regulators need to understand is that there will continue to be emergencies, and to put in place legally mandated clear emergency procedures for regulatory approvals of products. It could be vaccines, it could be medicines, it could be diagnostics, because we will have future epidemics and pandemics coming our way. The next slide. So finally, I just want to conclude by saying that pharmacovigilance and risk management is important. And only yesterday, we convened the African Advisory Committee on Vaccine Safety, a group of African experts put together who would help to support the strengthening of pharmacovigilance across the continent in all the countries. They will provide independent advice. They will assess the systems. Yesterday, they made some critical recommendations. And one that I think I want to just quickly mention is the fact that we are looking at public health facilities that are government owned, but there are a lot of private facilities which will also be involved in immunization. And we need to pay attention to see how we can gather data from these sources as well. And I'll end here, and I want to thank you very much for your attention. I'm very happy to participate in the discussions to answer any questions of clarification. Thank you very much.
Thank you very much, Professor Diki Akanmori. I think that was really very interesting to hear that steps have already been taken to start preparing countries, not only for the emergency registration of the COVID-19 vaccines, but as you conclude by saying that it will also be equally important to make sure that the pharmacovigilance system be strengthened, established where doesn't work very well, to make sure that these novel products are followed up quite properly. So thank you for this presentation. Looking forward for some of the questions. So I would like now to invite our third and last panelist, Monsieur Jean-Cédric Meus, who is going to discuss the system to support coordination of COVID vaccine delivery. So this will be one of the critical area really that will either make or break really the vaccination drive against COVID-19. So Mr. Jean-Cédric Meus is really what we call a veteran in the supply chain management, currently serving as the regional chief of supply for West and Central African region for UNICEF. Meus Jean-Cédric has really extensive experience in both emergencies, but also in country logistics activities, having supported operation in several developing countries, including the response to the Haiti earthquake in 2010, the deployment in Pakistan, Niger, Sierra Leone for different immunization operation, Liberia during the Ebola outbreak, Sudan, the Democratic Republic of Congo. So I think really this is a very, very rich experience. So I'd like now to kindly invite Jean-Cédric to give his presentation and to help us to stick in the 10 minutes so that we can have finally the time for discussion. So over to you, Jean-Cédric.
Thank you, Dr. Richard, for this introduction. Thank you also for allowing me to present here on the downstream logistics activities for the COVID vaccine. And thank you to my fellow panelists that make my work a little bit easier by giving the scene and the complication we have with this introduction of a new vaccine. So this is a joint work from the COVAX facility, WHO, PAHO, UNICEF, and of course Gavi, supporting the introduction, the procurement, and the dispatch of the COVAX vaccine to come. So I will stick it really as short as possible to allow more discussion afterwards. But what are we talking about? We're talking about unprecedented situation. As Professor Gregory said, it has never been done in such a short time. We're talking about 2 billion doses. I put here on the bottom the normal timeline for an introduction of a vaccine. Here we're talking about a decade before we have a host government being able to introduce a new vaccine. Now we're talking about a reduction of timeline over 1 year, 2 years. So it's an unprecedented, but also, as my colleague said, it's not new. We have host government that are able to do this. We have seen during the pandemic at the moment and the continuation of routine immunization. We have seen this through every routine outbreak, emergency outbreak, as the Ebola, but as the regular measles and yellow fever outbreaks that we are facing on the continent. So I'm going to skip through the different slides to keep it as short as possible and allow a longer conversation. But we are talking about, at the moment, 1.6 billion doses that needs to be produced, procured, and delivered to all the different countries that are on the map. The color code is different by self-financing without support from Gavi, and countries that are supported by the Gavi Alliance. So what is going to happen? First of all, it's not that complicated. I might be trimming this down and make it much easier, but we have to remember our continent is organizing routine immunization on a daily basis. It is controlled and managed by the host government, by the Minister of Health. So what are we talking about? We're talking about an additional 20% of the population, which is basically a measles campaign, which is organized regularly by most of the countries of the continent. So we have already pre-established working groups within the Minister of Health. We have seen with the reintroduction of new equipment for the cold chain equipment recently over the last 2 years, we have introduced more than 20 100,000 new fridges in Western and Central Africa, not talking about Eastern Africa and Southern Africa, but this is something that we have been doing. So we have pre-established working group. It's just a question of reintroducing the new vaccine, making sure we are working on the pre-established systems that we have. Now, the timelines is basically we are already now working with multiple suppliers to make sure that we have the right product. You have seen on the news already 3 of them have been certified. We estimate that by quarter 2, we will have the first deliveries of the supported vaccines. This doesn't avoid countries, host government to procure by themselves, but making sure that the vaccines is certified. Making also sure the complication will be the introduction, the complication will be the distribution, making sure that if you buy a vaccine yourself, you are matching the same specification of the vaccines that will be supported by the Gavi Alliance. Why? Because we are talking about ultra cold chain vaccines that require -80 degrees, that require specific dedicated supply chain, more costly. Or we talking about single dose or double dose vaccines with normal temperature up to -8 or -20. So having multiple vaccines, multiple specification will make the supply chain even more complicated. Complicated. So what have we done with the Alliance and with all the partners that I mentioned? We are working on the readiness activity, making sure that we are looking at existing facilities, the logistics capacity, the distribution capacity, but also matching the timelines of routine immunization that we don't want to disturb. We want to make sure that we don't have to organize another campaign because of an outbreak, because failure on the routine immunization. So really continuing the focus on the routine immunization in all the countries of the continent. So matching what's going to be available with the capacity of the host government, looking at the private sector, looking at all the partners of the respective Minister of Health, how we can then help to reach all the beneficiaries. Now, this is a different campaign. We are not looking at, we are not talking about children between 1 and 5, which is the normal routine immunization target population. We are talking about a different target population. We're talking about the first 20% that will be allocated to the countries of the host of the continent. We'll look at 3% for the health workers, which are easy to reach. Then the remaining 17% will be allocated by the host government in collaboration with WHO, UNICEF, and all the different partners to make sure that we're reaching the vulnerable population. But we're also looking at all the different administrative actors that are continuing on the fight for the COVID and continuing bringing the other equipment that we need, the protective equipment for the population also. So it is a little bit more complex than the normal one, and therefore we created all these tools on the readiness exercise to make sure that we are mapping all the different sequences and different steps of this introduction and delivery. So I'm not going to talk too much about all these exercises because they can be shared. We can share with you all the different links where you can find for your respective countries how ready you are, what needs to be done, and how can we not making sure that we don't delay the introduction and the delivery. So how is it going to happen? Looking at the priority, making sure that we have a clear understanding of the capacity of every host government, every Minister of Health in the storage, in the distribution, and make sure that every person that will be identified to be receiving the first batches of COVAX vaccine will be receiving this in due time. Making sure that the mode of transport is regulated, that we have all the different equipment in place from origin to destination. Schematically, this is draft, but we're looking at consolidation because we want to make sure that we can deliver to the maximum countries a sufficient quantity to have the first campaigns. We don't want to have countries that are receiving 1%. Organizing a campaign for 1% of the population might be too costly. So we want to have sufficient quantities. During the first part of this year, we had India that was landlocked. that was blocked. Most of our vaccines are coming from India. So what we did, we organized charters in Western and Central Africa to reach 13 different countries with 2 flights. It unprecedented, innovative way, but that success avoided any interruption in Western and Central Africa on routine immunization. So we're looking at the same principle, lesson learned from Ebola immunization campaigns, from Ebola vaccination campaigns, sorry, and from the previous complication we had during the COVID, during the first year, to look at consolidation and then going to the south to all the countries of this region. So in short, this is how we want to do, but once again, it is unprecedented, but not impossible because of the long-term experience of our Minister of Health on the continent doing routine immunization, at the same time managing outbreaks here and there over the continent. Thank you for listening. Over.
Thank you very much, Jean-Cédric. I think that was really interesting and also highlighting all the complexities that we are going to go through to deploy these vaccines. So thank you very much indeed. So we are going now to open the floor for the question and discussion. But before that, I would like to kindly invite Dr. Mohamed Hassani, the Assistant Minister of Health from Egypt, would like to take the floor to update us on the preparedness to receive and produce vaccine in Africa from the Minister of Health perspective in Egypt. So, Your Excellency, I would like to give you the floor maybe shortly so that we can hear your perspective and then open the floor. So, Dr. Mohamed Hassani, over to you. Dr. Hassani, can you hear us? Okay, so I think we'll get back to him. So let me open the floor for the discussion. Sorry, we had some electricity cut here. Let me start by Professor Greg. You really mentioned the issue related to what are the lessons and the past experience of new vaccine introduction. We have heard from Jean-Cédric that this will be like any other, unlike any other experience we have gone through in the past. Indeed, countries have got some experience in deploying vaccine, but this will be a completely different game. So from your perspective, Professor Greg, and using some of the data that Jean-Cédric has mentioned, the WHO UNICEF readiness assessment tool, we have estimated that the average preparedness level at regional level, it's around 36%. So countries are not yet ready to deploy this vaccine overall. So what will be your advice moving forward in accelerating preparation and particularly building on the past experience? Professor Greg?
Thank you, Chair, for that question. I think it's important that we empower people to take ownership within the countries in terms of what they should be doing and how they should be doing it. I mean, it may sound quite bad that the sort of average country readiness is sitting at about 36%, but I think we need to involve all the stakeholders. And I think the important point is the fact that it's not only the governments of the day that can play a role. There are a whole list of other groups, and I think it was alluded to early on as well. People in civil society, NGOs, CBOs, faith-based organizations, public-private partnerships. So I think this calls for a concerted effort by everybody within every single country to ensure that we are ready to make an impact on the epidemic. And I think it's for each country to look at how they can do that. But we mustn't underestimate the power
Thank you very much, Professor Greg. I think you are asking us not to be too conservative. I think that's very good advice. Let me turn on to Professor Dickey. You mentioned one important element, pharmacovigilance. We are going to receive several new vaccines, several products that have not yet been used at a large scale, as we know. How confident are you about the system that has been established in the country to make sure that any adverse events that were not picked up during the clinical trial will be properly not only notified, but also detected and managed? Can you tell us a bit on the level of preparedness of country moving forward on that regard? Over to you, Dicky.
No, thank you very much. This is an excellent question. And indeed, preparations towards this actually began last year, because at the GACS meeting, there were discussions around what happens when we have to monitor vaccines which are not licensed, but which have to be used in a wider population. And so those discussions began as far back as the last, GACS is the Global Advisory Committee on Vaccine Safety, which advises WHO on vaccine safety globally. I've lost power here, but I'm sure you can still hear me. So that's the first step. And then subsequently, in May this year, GACS met and they came up with a plan and set up working groups to develop a global safety manual for COVID-19 vaccines, identifying what potentially could become adverse events which are not yet well characterized events, which we call AESIs, or adverse events of special interest. Now, in addition, GACS, the manual addresses the different aspects of vaccine safety. And this manual is intended to be used by all countries. It's been completed now. It's awaiting formal approval, and then it will be on the WHO website to be distributed to all countries to help them set up systems, strengthen the systems that exist, and ensure that they are able to monitor adverse events during immunization. But the point you make about these vaccines being new, and that then also means that it's not enough to look for the routine events that we see, that we know, that we record, that we analyze and share information on. We also need to have in place some special studies which will enable us look for events which may have been missed in clinical trials, or which may have occurred with such low frequency, they were not taken into account. And for this to happen, countries have to have systems for these special studies, define sites, either the sentinel sites or they're going to be cohort studies, but they need to invest in these efforts to ensure that we are also generating information which will advise and help us, implement these vaccines safely, and to also look at their performance in addition. Over.
Thank you, Dicky. Vigilance will be critical as we definitely roll out these products. I'm going to go back to His Excellency the Minister, Dr. Mohamed Hassani. Can you now hear us?
Yes, I hear you clear. Could you hear me now?
Yes, I can hear you. So please, the floor is yours. Yeah.
Thank you very much. Your Excellencies, Minister of Health and Ministers of Finance, honorable delegates, distinguished guests. It gives me a great honor and a pleasure to join you today on behalf of Her Excellency Dr. Hala Zaid, the Minister of Health and Population of Egypt. And I'd like to take the opportunity to honor the collective work of health care providers, scientists, manufacturers, policymakers, funders, and all the honorable personnel who participated in prevention, detection, and response to the COVID-19 pandemic. And I'd like to also emphasize the great importance of the continuous and the fruitful collaboration across the continent among African nations, showing a great model of solidarity and unity. Experiences have been gained in the development of vaccines for Ebola virus disease that allowed us to apply the important lessons we had learned in the public-private partnership, regulatory harmonization, clinical trials, and manufacturing process. Since the start of the pandemic, Egypt has been working proactively to engage our sustainable partners across the globe to help in securing the vaccine for Africa once available. And today we are witnessing a very crucial moment at the first of many COVID-19 vaccine doses are starting to make their way to distribution sites across the globe. With the upcoming challenge appears ahead, this requires us to ramp up all the required efforts of getting ready for what will be the African
So excuse me, Minister, can you speak a little bit slower, so that the interpreter can also catch up, so that,
oh, okay.
Sorry about this. So over to you.
Okay, you are right. With the upcoming challenge appears ahead, this requires us to ramp up all the required efforts of getting ready for what will be the African continent's largest ever immunization campaign. National strategies for vaccine planning, deployment, and continuous monitoring shall be implemented to ensure the achievement of health security for all the African citizens. Likewise, resources utilization and mobilization, fund allocation should be continued to secure the availability and accessibility to the vaccine without leaving anyone behind. Countries shall harness all the efforts and capabilities to ease the immunization ahead. In this regard, I would like to express Egypt's preparedness and commitment to fully cooperate with African CDC to fulfill and implement the African strategy. As Egypt is one of the main producers of vaccine in the region, the Egyptian Ministry of Health and Population, in cooperation with the WHO, went through several stages of assessing the Egyptian national company for vaccine manufacturing, named Vaxera, for reviewing the readiness of Vaxera for COVID-19 vaccine production process. The assessment of Vaxera ability and vaccine manufacturing facilities was carried out by the WHO team of experts in association with the Egyptian drug authorities in terms of its production capabilities and readiness of facilities, systems, and process of manufacturing of COVID-19 vaccine. And also the World Health Organization product pre-qualification. And according to expert assessment, and allow me to quote from the WHO final report, Vaxera has certain state-of-the-art manufacturing facilities which could be dedicated for production of COVID-19 vaccine in a short period of time. The institution also has a great technical capabilities and the human resources and technicalities in order to become a center of excellence for vaccine and biological production in the whole region, with additional and continued support from WHO. Finally, on behalf of Her Excellency, the Minister of Health of Egypt, I would like to reaffirm and commit to promote the health security throughout our continent. We will work together hand in hand and inclusively to secure the required production of COVID-19 vaccine and ensure the most attainable access to all the African people across the continent. Finally, I thank you.
Thank you very much, Dr. Mohamed Hassani. I think this is quite interesting. You raise a very good point on the local production of vaccines in Egypt. Yesterday, there was a lot of discussion around this topic, and we heard that it will be important. It will be important that not only on the short term, but in mid and to long term, that Africa gets the capacity to produce locally the vaccines that we need, not only to address a situation like this as a pandemic, but also to supply the regular routine immunization. So thank you very much for this commitment for the Egypt. So I'm going to move back to the colleagues and have one question to maybe ask Jean-Cédric if you can take this one. It has been raised that how are we going to make sure that people who are living in a very remote area, refugees, people who are not necessarily reached by the regular routine immunization services, are going to be targeted for COVID-19. Can you please give us some insights on what are the current discussion on making sure that no one will be left behind during this vaccination?
Thank you for this question. And this is really the hope. The objective is to let no one behind. There are 2 points on this. It's the logistics, but also the communication. We're looking at the introduction, we're looking at the logistics, we're looking at all these aspects of readiness. But one of the major points is also the communication, making sure that we pass the message of the benefit of the COVAX. We hear around the world a lot of fake news about the vaccination and everything. So the communication is first of all essential to make sure that we spread the information of the benefit of the COVAX. How to reach the vulnerable, how to reach the last mile, how to reach everybody. This is basically our daily job in many of the countries in this region due to infrastructures, due to the challenging infrastructures, but also to the natural disaster, droughts or floods, or to some of the insecurity that we are facing in some of the countries. So this is what we do in the routine immunization. This is how we also organizing immunization campaigns. But this time, and thank you to CDC and the African Union of organizing this, it is not only with the natural partners of the host government, but now we're bringing you also all the international private sector. We are working hand in hand with IATA. We are working hand in hand with UPS, with Bolloré, with the big companies that have a footprint on the continent, making sure that we can then reach and dispatch and distribute the vaccines to the last mile population. So we are mapping all this at the moment, as we were talking about the readiness, our capacity to store at central and decentralized level. What do we need to bring further? How many fridges or cold rooms do we need to procure additionally to what is already existing on the continent? And then making sure that the distribution channels are done to reach this last mile beneficiaries. But it is the most important, it requires a lot of coordination and a lot of communication and mapping the existing resources, and not only taking new private sector partners, but making sure that they have the adequate footprint in each and respective countries on the continent to reach the last mile beneficiaries. And that is the most important. What is possible in East Africa might not be possible in Western or Northern Africa, and the same thing for Southern Africa. So the mapping is crucial, and that's what we are working on now. Over.
Excellent, excellent. Thank you very much, Cedric. I think we are running out of time. This was very interesting discussion. I would just like to let know the different audience that the slides that were presented today are going to be made available through the colleague at Africa CDC. So you will receive this material at the end. So I would like just to take one last question. Maybe Professor Greg, if you can help to address this. 2 issues. First of all, how do we make sure that the other institution outside the government can be involved in the delivery of the vaccine, notably NGOs, faith-based organization, etc. And there is an interesting question coming from one of the attendees asking how can also the business or private sector can help to increase the capacity for delivery of the vaccine going beyond the traditional EPI program. Can you briefly give your perspective on those issues?
Well, I think that, thanks, Chair. I think those are good questions. I think there's been a tradition of involvement of NGOs in terms of supporting countries with immunization activities, especially in times of crisis, and MSF is a very good example. Locally in South Africa, as well as on the continent, Gift of the Givers. So I think there are very good examples of where NGOs and faith-based organizations have supported countries in terms of providing vaccines for people at need. And again, it comes back to the issue of partnerships. We tend to talk about partnerships between countries at a very high level, but we don't tend to talk about partnerships within countries. So how do we empower ourselves in country by making people part of a collective to tackle a big problem? So I think it's about communication, it's about advocacy, it's getting people involved in issues. And this is where the private sector plays an important role. I mean, the private sector, certainly just speaking from the South African context, have contributed significantly to a solidarity fund for COVID over the last year. And we need to look at how the private sector can play a role. The private sector have played a role in the past in many African countries. There are vaccines that are distributed within the private sector. There are private clinics that are used to provide vaccination for people. And we need to look at how do we bring those practitioners, those private business people into a partnership with government to make sure that we can reach everybody. Thank you, Chair.
Great. So thank you very much, Greg. And I would like really to thank the three panelists. You have been really terrific. We will definitely continue this discussion because we have only started this conversation. We know that we need to accelerate the pace to support countries. I would like really here to thank my brother, John Kengason, for the leadership that the Africa CDC has taken on this aspect. We at WHO indeed are going to work hand in hand with Africa CDC to support the countries. We will definitely, one participant asked a question, what are we expecting from you? I think since yesterday, the conversation that started, and then today, we've had a quite diverse audience. You have seen policymakers, technical people, members of the NGOs, scientific community. I think we have raised a lot of issues that can be definitely addressed at the different levels. So what we are expecting from you is to take on some of the key messages that has been discussed since yesterday, and in your own personal capacity to see how you can also try to make the difference where you are. So I would like to thank everybody. It has been quite a short but interesting. And I would like to introduce the next panel that is going session 4, that is going to discuss the framework for equitable allocation of COVID-19 vaccines. So thank you very much. The discussion will continue, and I would like to hand over to the chair for the next session. My sister, Margaret.
Hello, good afternoon, good evening, good morning, wherever you are. Thank you so much, Dr. Richard Mihigo, for that very good and interesting session. Allow me to now take on the next session, and the session is going to focus on a framework for equitable allocation of COVID-19 vaccines. And before I proceed, I want to take this opportunity to thank the Africa CDC leadership and the South African Medical Research Council for jointly convening this conference, which is proving to be very useful in informing all the key stakeholders on how best we can work together to ensure that we have a framework for fair, equitable, timely allocation of COVID-19 vaccines in Africa. So my name is Margaret Ndomondo Sigonda. I'm the head of health program at the African Union Development Agency, AUDA NEPAD. I'll be co-moderating this session with Dr. Mongezi Mudluli. Dr. Mongezi Mudluli is the Chief Research Operations Officer at the Southern Africa Medical Research Council, and he is essentially a member of the Executive Management Committee, providing visionary leadership, strategic management, and excellence in the development, implementation, management, and oversight of the SAMRAC strategic goals and objectives. And he will be taking us through the brief overview of the session. And then, of course, he will also be setting out the house rules for the session before we can then invite our eminent speakers. We have 3 of them. We'll be introducing them one by one before they make their presentation. So I want to take this opportunity to welcome my co-moderator to take on this session and provide the overview for the session. Over to you.
Thank you very much. Thank you, Your Excellencies, participants, and the. Sorry, I'm getting a bit of an echo here. Thank you. So, Your Excellencies, distinguished guest speakers and panelists, and all participants, and thank you to my fellow co-moderator, Dr. Margaret. As I've already indicated, my name is Mungezi Mdluli from the Medical Research Council. So I'll just quickly give you a brief overview of the session, this session 4. So the goal about this session is all about the framework on fair allocation of safe, effective COVID-19 vaccine that will reduce transmission, morbidity and mortality, and decrease the negative societal and economic hardships in Africa. So we do understand, and looking at all the presentations that we had from yesterday and today, that the allocation framework will be based on some uncertainties. Now, how do we address those uncertainties? Is we have to draft a framework. So today in this session, we are fortunate to have 3 speakers that will help us to navigate this framework. Firstly, we have a speaker that will talk about a presenter that will talk about the framework with African indigenous or ingredients values. In this one, we heard yesterday from a roundtable discussion from the former Minister of Finance in South Africa, Mr. Trevor Manuel, a quote. He said, dispersal in Africa, in African continent are different to those elsewhere in the world. So with those words, it is clear, I think, to all of us that a framework on fair, equitable, and timely allocation of COVID-19 vaccine in Africa must, among others, incorporate and be guided by African indigenous values, ethical principle. To address this, we will have Professor Mfutso, however, Mfutso Bengu, however, my co-moderator will be introducing him later on. The second presenter will talk about the framework that is based on epidemiological considerations. Here we'll be talking about who or which persons are affected or mostly affected by the disease, how and why is this disease transmitted, and the risk factors associated thereof. Again, from yesterday's session, we heard about the importance of vaccine allocation criteria, how vaccine and healthcare are a global public good, and the potential negative economic impact on Africa should we fail to vaccinate our people. In this regard, we will invite Professor Shabir Mahdi to assist to navigate this area. Our last speaker will talk about the framework that takes into account the special people or special circumstances. Yesterday, again, we heard about that, and today, that no one should be left behind. However, in this session, we'll talk about just narrowing this concept of no one should be left behind to a specific area, talking about specific people or special populations and conflict-afflicted persons that should not be left behind. With those words, let me just quickly go through the house rules before I give it back to my co-moderator. Firstly, if I could ask all the presenters to make sure that their microphones are muted while the other presenter is on the podium, as well as the phones that are in silent. And when we take the Q&A after the third session, the third speaker, I will ask all the speakers to unmute their phones and their microphones. I will invite all participants that would like to pose questions to put it on a chat or on a Q&A tab so that we can get those questions. So with all those small words or few words, I would like to give it back to my fellow co-moderator to introduce the speakers, the first speaker. Thank you.
Thank you, Dr. Mugezi. So allow me to now introduce.
Okay. So I see that my fellow co-moderator is not there. Let me take it. The first speaker will be talking to us about the African and indigenous values towards the equitable allocation of COVID vaccine will be Professor Joseph Mfutso. Professor Joseph Mfutso Bengu is the head of department at the University of Malawi and director of Center of Bioethics for Eastern and Southern Africa. Professor Mfutso Bengu is one of the leading bioethicists in Africa. He's a professor of bioethics and health sciences at the University of Malawi, as I've indicated. He's currently head of department and director of that center that I spoke about. He chairs the National Advisory Bioethics and has published numerous articles in Africa and international journals on issues in healthcare and research ethics. His latest publication is a book on moral capital and lex framework. And I'm also happy to introduce him as also part of the South African Medical Research Council Advisory Panel. With all those words, Professor Mfutso Bengu, the floor is yours. Thank you. You've got 15 minutes to do your presentation. If you're ready, you can put on your slides. Thank you.
Can you see my slides?
Yes, please go ahead.
Can you see them?
Yes, we can see your slides. Please proceed.
Okay.
Can you please unmute yourself? Or the organizers, can you help Professor Mfutso to unmute him?
I've unmuted myself.
Yes, we can hear you now. If you can start from the beginning.
I think Joseph is now muted. He needs to be unmuted.
Sergey, are you able to assist Prof?
Can you hear me?
Yes, you've unmuted yourself now, Joseph. Don't touch your mute button.
Yeah, okay, thank you.
Yeah.
Yeah, I just wanted to say the African indigenous values towards equitable allocation of COVID-19, we cannot understand without understanding the concept of personhood. I will take you to John Beatty, who said, I am because we are, I am. So a human person becomes human through not only thinking or rational, to be rational, but also relationship. Human being, according to the African concept, is intrinsically has to do with interrelatedness, interconnection, interdependence. And this, we are doomed to be interdependent, interconnected, interrelated. So I take you to understand that when you're also talking about human person, we are looking at this interrelated of a human being to do also with the body, mind, and soul. And I think it is very important to understand that the concept of health influences the understanding of person. Also, these are to understand of health. So the interrelatedness, interconnected, and interdependence is two aspects, within and without. And when we are talking about within, we're talking about the living dead, the living spirits, future generation, creation, creator, and that also includes the body, mind, soul. Harmony within the is also compared with the WHO concept of human person, that is not only absence of disease, but a complete state of complete mental, physical, social well-being. So there are two types of harmony. Harmony without is the harmony with others, including the global community health. It is also talked about extended family of all human beings. So both physical and metaphysical well-being have to also be understood by what we call ethical wellness, which is the harmony is not only the bodily harmony, but also the harmony which comes by doing what is right and doing what is good. So community health is global community health. What do I mean? Community health is about community health problems, issues, concerns that affect not only individual, but a group in a particular geographical area may also be influenced by circumstances and experience and behaviors. But as we see that community health is also global community health. You cannot talk about community health without looking at the global aspects, that we as human beings, we are interrelated, interdependent, and interconnected. So the wrinkle concept of personhood and community health. Personal health is dependent on African global community health. The concept of immunity, what is common good, one needs participation of others for successful implementation of immunization. Disease prevention and control requires the understanding that humans are interdependent, interconnected, interrelated. So community participation, interdisciplinary, intersectoral approaches are key to primary and global health. Individualistic understanding of person in form of vaccine nationalism and vaccine hesitance could affect community health, disease prevention control, both at community, at local, at global health. So Kate Bosom said one day, nothing on earth is more international than disease. Global community health is not optional, but is a necessity. And the global community health and solidarity is a common sense. African proverb, if you want to walk fast, walk alone. And if you want to walk far, walk together. Is common sense common among nations? Why do we not walk together? Why do human beings move forward? They want to move forward by leaving others behind. So I take you to the scramble of COVID-19 of vaccine lesson to be learned. Why many policymakers talk about evidence-informed decision-making has demonstrated that science and evidence is not enough for equitable fair allocation. You need values. Hence, decision-making of countries require to be informed by both values and evidence. Evidence alone will not take us shown that cannot solve the issue of equity. Knowledge is not the same as wisdom, and truth is more than evidence. So there's a need to come up with value proposition to guide the fairness and equity access of COVID vaccines. We propose to consider the universal concept of Ubuntu derived from African indigenous value system. I'm calling it universal concept, which is a contribution of African indigenous value system. Global community health requires global solidarity and partnership. Leaving Africa behind in access of COVID-19 vaccine is not only a question of economics, but also is moral and ethical in nature. I want to show these 4 pillars which were developed by Mlongezi, Amsda, and Grande, which talks about the 4 pillars of Ubuntu: affirming humanity of others, survival of community, and social solidarity and meaningful community engagement. This is a summary of what Ubuntu could be for this context. So I would like to go into them just to explain what it is. Yesterday they were explained, but I go fast today. By affirming humanity, we are talking about promoting common good, while at the same time respecting human dignity. Every person is considered and treated as having equal dignity, worth, and value. Social benefit is broadly understood in the context as having health and the socio-economic well-being of public. We can also say that when we're talking about the human dignity, it means that the respect of human dignity should be non-discriminatory and should be regardless of race, ethnicity, nationality, etc., etc. Survival community, we're talking about allocation of decision have to be informed by both values and evidence. So vaccinations, specifically who received the vaccine or when should be based on best available evidence. But also here they talked about the survival of one is the survival of all. You cannot strive for the survival of all without ignoring the survival of one. Social solidarity. As we know that a human person is interdependent and interrelated and interconnected, solidarity is not an optional. It is a necessity. So the moral right to equal consent requires allocation of vaccine to proceed impartially according to fair criteria. People are to be treated fairly and equally. And when we move out to meaningful community engagement, it follows about promotion of legitimacy, trust, and ownership. And what includes also management of fake news and misinformation. Community involvement will be required for promotion of regional and global approach for resource allocation in addressing vaccines, hesitancy, and vaccine nationalism. First, with the challenge of maintaining public trust, while simultaneously stemming the pandemic through various control measures. Decision-making need to be trustworthy by ensuring early engagement with stakeholders. And for this integrity, which reflects the need to act with honest reliability and fairness, and the willingness to be held accountable to expense one's action. So the ethical dilemma of COVID-19 vaccine allocation can be summarized with two words, can and ought. The fact that one can mean that one ought to. How far we ought to when we can. Vaccine nationalism and monopoly. Which international instruments could you convince or prevent the powerful countries not to unfairly monopolize the acquisition of all COVID-19? Leaving many countries behind without none. Ought one country buy more vaccine than it needs? Pricing of COVID-19, according to, should all countries pay the same price regardless of being a high, middle, low income country? Dilemma of low income countries with low COVID-19 cases, mortality rates, should they borrow for COVID-19 vaccine at the expense of development activities? Don't trap. Why not seeking grants like Global Fund mechanism for HIV without having controlling of timing and quantities? So there's this dilemma where we have to borrow or we have to depend on grants, which we do not have control. But the question, should the poor countries with low mortality rates acquire debt for consumption when they other facilities? The risk of using COVID-19 vaccine to limit mobility from low to income countries. There's also the risk that a COVID-19 vaccine could be used as instrument of limiting trade and the movement of people from low-income countries to high-income countries, and even preventing investment to say that the country having that country as a risk area.
Can I ask you to wrap up, please?
Yes, I'm now going. Yeah, so it's actually I'm going to the recommendation. Draw a declaration on compassionate use of patents for public health interests. Will Africa stand together as a bloc in a negotiation, or is it for a victim to divide and rule tactics? And I just wanted to say, I will not talk about that. Just scientific inequity need for global solidarity in the spirit of Ubuntu. I think that who defines inequity as preventable and fair differences in access, 1090 gap in research capacity, vaccine and development and access, it is there. And the unfair, though preventable differences in capacity vaccines in development is already there. So 90% have no access to COVID-19 vaccine at the moment. So I just wanted to say that it's unethical to leave to leave a population of Africa behind. I also want also that if Africa can consume 40% of global vaccines, and yes, does import 95% of its vaccine, can Africa utilize this market by increasing research, development, and production, like what our European partner did, Airbus versus Boeing, where Airbus, 4 or 5 countries came together, Germany and others, to create Airbus? How will Africa solve this gap in terms of vaccine research, development, production? There's a need to revisit Africa global value system. So I just wanted to say the African value system, the colonial value system, which were indigenous, and then there's a colonial value system, which are based on divide and rule, dependence, vertical relationship, monologue, a less horizontal relationship, Afrophobia, fearing no fellow Africa, and the post-colonial values is we need to see people talking about African renaissance. They're talking about decolonization, but we need to come to quantify or qualify what do we need, what we call post-colonial African values. Africa is finding itself in an uncommitted middle where it is neither traditional or modern. We find that we are in this dilemma where we are losing some of the traditional values, and yet we are not abiding to the principle of social contracts. So the last one, I just wanted to say that I've already, these are the principles which could also guide common good, necessity, proportionality, responsibility, equity, solidarity, common sense, integrity, and community engagement. The final recommendation is, I think there's a need to African Union to go political union, beyond political union to cultural empowerment. There's a need for joint multinational production of medicine and vaccines, because according to Ubuntu, it's not only unity, but also it's not, this unity is based on interdependence, not dependence. Dependence is not part of Africa values. Promote Africa regional pool procurement, create our own African Medicine Agency, and I think there's a need to advocate for responsible financing of COVID vaccines. And at the end, the law of, as conclusion, I think we need to understand that there are 3 cornerstones which will guide implementation: good leadership, ethical engagement, governance, and good system. Thank you.
Thank you very much, Prof. You're very passionate about your work. Just to briefly go through what you've said, you've raised issues around the community health as a global community health. You spoke about the personhood and community health that are interrelated or are linked. And quite importantly, as we know, the pandemic, the P in the pandemic means something that has got a passport, and you say nothing on earth is more international than a disease. So it can cross borders, it cannot affect only one country per se. And then you spoke about the common sense may not be necessarily common to all. I mean, what's common to one may not be necessarily common to all. You spoke about the 4 pillars of Ubuntu being humanity, others, survival of the community, social solidarity, and the meaningful community engagement. You also gave us some understanding on the ethical dilemma, the scientific inequity, and the need for global solidarity in the spirit of Ubuntu. And you spoke about how it is important to have a post-colonial values. And in your closing remarks, you said Ubuntu is all about interdependence, not dependence. Thank you very much. Let me just check with my fellow co-moderator whether Dr. Margaret is available. Are you available to introduce the second speaker?
Allow me to also thank Professor Bingo for the very insightful presentation. Now it's my honor to introduce to the audience Professor Shabil Madhi. Professor Shabil is Professor of Vaccinology at the Wits University in South Africa. and is also a co-director of the African Leadership Initiative for Vaccinology Expertise. He currently also holds the position of a director for the South African Medical Research Council Vaccines and Infectious Diseases Analytical Research Unit, but also is a research chair in vaccine preventable diseases of Department of Science, Technology, National Research Foundation. And he also has co-authored more than 460 scientific manuscripts since 1997. I have the honor to invite Professor Shabi to make his presentation on epidemiological consideration for COVID-19 vaccine allocation. Over to you, Prof.
So thank you, Margaret, and good afternoon to everyone. And thank you for this invite to chat to you about what my thinking is around where COVID-19 vaccines should be deployed in Africa. And I'm going to use South Africa as a case example, partly because I'm from South Africa, but also partly because, unfortunately, because of circumstances, much of the initial data in terms of how COVID-19 has affected Africa is coming from South Africa. And then briefly, I'm just going to share with you 2 or 3 slides in terms of initial experiences with a COVID-19 vaccine trial that is currently being undertaken in South Africa. Now, I think one of the major challenges that we face in Africa is our inability to fully characterize the burden of COVID-19, either in terms of number of cases or number of deaths. And I think we really need to be careful when speaking about COVID-19 in Africa and what a great job we've been doing, and that being the reason why Africa has not actually been as severely affected compared to Europe and the United States as an example. And going back to Prof. Greg Hussey's earlier presentation, the experience with swine flu in 2009 was that less than 5% of the swine flu cases during the course of the pandemic were actually reported from Africa and from South Asia. Yet when the swine flu pandemic passed, more than 50% of all of the deaths from swine flu were eventually identified to have occurred in Africa and South Asia. So the narrative that Africa is not being affected as much by COVID-19 inadvertently can lead to Africa actually being deprioritized in terms of gaining access to COVID-19 vaccines. Now, when we talk of gaining access to COVID-19 vaccines, as Prof. Hussey had pointed out, it's particularly unhelpful to eventually get access to vaccines when a pandemic has passed. So what do we know about COVID-19 in Africa? And these are data which are familiar to most of you. So I'm not going to labor too much on the data itself. These are data from the 20th of November, at which stage Africa, which constitutes 17% of the global population, were reporting less than 5% of COVID-19 cases and deaths. Now, when stratified further into African countries, we see a disconnect in terms of population size and the reported number of COVID-19 cases and deaths. South Africa, which constitutes less than 5% of the African population, was reporting roughly 40% of all COVID-19 cases and all COVID-19 deaths in the whole of Africa. Whereas Nigeria, which constitutes 15% of the African population, was reporting less than 4% of all of the COVID-19 cases and deaths in Africa. Now, one of the major differences between these countries, and right on the right-hand side of your slide on upper right part, you see the testing rate per 1,000. And I think this is familiar to all of us, but it's something we seem to neglect when speaking about a burden of COVID-19 in Africa. And that is South Africa's testing rate is roughly at about 90 per 1,000 of the population, compared to Nigeria's testing rate of 4 per 1,000 of the population. So it's really difficult to make any sort of judgment call as to just exactly how Africa is being affected by COVID-19. And again, the narrative that COVID-19 is not causing much death in Africa, I think is a dangerous narrative. Because like I said, if that is going to be the narrative that we deploy, it essentially puts us back in terms of being able to gain an equitable share of COVID-19 vaccines moving forward. Now, even South Africa, despite doing more testing than any other African country because of the resources available to it, looking at different modeling different models from different groups, even in South Africa, where our testing rate is 90 per 1,000, it's probably roughly about a quarter of the testing rate that's being undertaken in the United States, and probably less than 50% of the testing rates that's undertaken in many other high-income countries. So at a time when South Africa was reporting about 14,000 new cases per day, adjusting for the positivity rate of the tests and the number of tests that were being done, the estimates was that the actual number of new cases per day in South Africa was in the region of 45,000 to up to 90,000. So even in South Africa, there's been a systematic under-documentation in terms of COVID-19 cases, as I'll show you from zero surveys that have subsequently been done. Now, what are we facing in South Africa? What we're facing right now is a resurgence in many provinces in 4 of the 9 provinces in the country. And as you can see, the magnitude of this resurgence seems to pretty much becoming very close to what was being experienced for the first wave of the outbreak. Now, this is especially important when talking of COVID-19 vaccines. I think it's really aspirational to talk about leaving no one behind. But for me, the bigger issue is not about leaving no one behind, but about actually getting some meaningful access to COVID-19 vaccines in the immediate future before we have multiple waves of COVID-19, which essentially would inadvertently lead to the probability of herd immunity evolving because of natural infection rather than because of vaccination. And that is not by design. That is going to be the nature of COVID-19 on the continent unless we get our ducks in a row in terms of being able to get adequate quantity of vaccine soon enough and not when the pandemic had passed. Now, in addition to COVID-19 cases, like I mentioned, there's been a systematic under-ascertainment in terms of COVID-19 death as well. And this is an experience from high-income countries and how it compares to South Africa as an example in terms of the excess mortality in relation to the actual documented COVID-19 deaths. So for many high-income countries, what you observe is that the area under the curve of the excess mortality and the documented COVID-19 deaths is round about 0.9 to 1. There's very little difference in terms of what is modeled as excess mortality and the actual documented COVID-19 deaths. And what the figures you see is a mortality rate per 100,000. In South Africa, as an example, which, like I said, probably has got the most robust testing in the whole of the African continent, in fact, the excess mortality far exceeds the actual number of documented COVID-19 deaths. We're only detecting only about 25% of the COVID-19, of the deaths that are probably attributable to COVID-19 are being documented. Now, when you use this data and you try to calculate the actual incidence, if you were just to look at COVID-19 deaths reported, the incidence per 100,000 in South Africa is in the region of about 35 per 100,000. But when you assume that almost all of this excess mortality is from COVID, and there's a strong reason to believe, to suspect that it is from COVID because of the trajectory of the excess mortality and the actual reported death, then the mortality rate for the first wave of the outbreak in South Africa for COVID was 90 per 100,000, which in fact is as bad as was observed in Belgium, one of the European countries most affected with COVID during the first wave. So there's been a systematic under-ascertainment in terms of cases as well as deaths from COVID-19. And as I mentioned, unfortunately, that puts us at a disadvantage in terms of being able to advocate why COVID-19 vaccines are important to Africa at this point rather than in a distant future. Now, there are some differences, however, in terms of what was experienced in Europe as an example, and I'm using Spain as an example, and South Africa as an example. So with the first wave in Spain, the percentage of the population that were infected with the SARS coronavirus 2 was less than 10%, ranging from under 2% in the coastal areas to up to about 10 to 12% in the inner part of Spain, in the Madrid area. In South Africa, on the other hand, based on serious surveys that were done in the Western Cape, in Cape Town Metro in particular, and similar sort of data that's now available from our vaccine trials, all indications are that as many as 40% of adults might have been infected with the virus during the course of the first wave of the outbreak. So how the difference that arises is that in the Western Cape, as an example, The reported COVID-19 mortality rate was 77 per 100,000. Using the excess mortality estimates, that incidence goes to 120 per 100,000. But where Africa seems to be differing from European countries is that the infection mortality rate, which we impute the denominator based on the zero surveys, the infection mortality rate is 0.3%, which is probably about 1/3 to 50% of what was actually experienced in many high-income countries. So our infection mortality rate seems to be lower, but in terms of absolute incidence, the mortality rate in South Africa, as an example, has been higher, if not equal, to what was experienced in many European countries during the course of the first wave. So who is it that's dying of COVID-19 in Africa? Now, one of the reasons that has been proposed as to why Africa has been less severely affected than many other European countries or other high-income countries is because of our population demographic differences. In particular, a lower percentage of people over the age of 65. And that holds true for South Africa, where only 5% of our population are over the age of 65, compared to about 20 to 22% in Spain and Italy, as an example. But offsetting that age group demographic advantage is a very high prevalence of comorbidities, which are also known to cause severe illness and deaths from COVID. So in South Africa, as an example, almost 45% of adults would have hypertension. Roughly 10% of adults would be diabetic. Amongst women, more than 40% would be obese. And there's a high prevalence of smoking amongst men. So when looking at hospitalization in South Africa, what we observe is that the peak in terms of incidence of hospitalization, not surprisingly, is higher the older individuals come, and that is on your right-hand side. That is your incidence per 100,000. But looking at age group structure of those people that are hospitalized, we find that the peak age of hospitalization is in the region of 45 to 70 years, which is very dissimilar to what is experienced in many high-income countries, where the peak age of hospitalization is in a region of 65 to 80 years rather, in terms of percentage of people that are hospitalized. When looking at those individuals that are hospitalized, we find that although there's some data that's missing here, a large percentage, we don't know whether they've had comorbidities or not. Importantly, 40% of individuals do have at least one comorbidity, but up to 1/3 of individuals, in fact, don't have any comorbidity. Now, that has got important implications in terms of planning who to target for vaccination, because if we very focus on our vaccination, it means that we're still going to get substantial number of cases of COVID-19 in the near future. When looking at those comorbidities that are associated with hospitalization, we find that age over above 65, hypertension, diabetes, makes up roughly about 3/4 of all of the individuals that end up being hospitalized where a comorbidity is known. So that obviously assists us in that those individuals with hypertension, diabetes above the age of 65 as an example, and those are conditions that are very prevalent, would need to be prioritized for vaccination. When looking at mortality, people dying from COVID-19, again, a very similar sort of a picture in terms of case fatality risk on your right-hand side. It increases exponentially beyond the age of 50, 55, right through to 80 years. And we find a slight shift in terms of the age group that are most represented amongst those that die, moving from 45-year age group to about 55 years and up to about 70 years. So there's a shift to the right in terms of the age group structure of those that end up dying from COVID-19. So this is just a risk analysis, and all of this data from the National Institute for Communicable Diseases, which basically gives us a sense in terms of which factors are most are independently associated with a poor outcome. Not surprisingly, as an example, people over the age of 65, their risk of dying is about 15 times greater than those that are hospitalized between 0 to 19 years of age. People with comorbidities, hypertension, diabetes, as I mentioned, their risk of dying relative to the absence of those conditions is about 1.5 to 2-fold increase. But again, these are data which assist us in terms of identifying, at least for hospitalized cases, which individuals are more likely to have an adverse outcome in terms of death. So I'm going to now just share with you 2 slides in terms of the first COVID-19 vaccine trial, which was started off in South Africa in June. And I'm just going to really talk about the co-primary objective. That was to look at the efficacy amongst individuals that were negative for infection at the time of enrollment, and some of the challenges that arose in this particular study because of largely what I've just described, that COVID-19 in terms of its impact in Africa has been completely underrepresented. So what happened in South Africa is that this vaccine trial actually started very much at the time of the peak of the outbreak, around about the middle of July. That's in the black bar. The black line shows you the individuals that received the first dose of vaccine, and the blue bar shows you individuals that received the second dose of the vaccine. As you can see, by the time we had enrolled 1,000 participants, we were very much on a downward trajectory from the first wave. And very few individuals, in fact, had received the second dose of the vaccine by the time the first wave had plateaued off. And consequentially, what ended up happening is that we weren't able to accrue a sufficient number of endpoint cases that occurred at least 2 weeks after the second dose of vaccine. So we are still, the study is still ongoing to try to get more endpoint cases. And because of the resurgence in South Africa, it's very likely in the course of the next few weeks, we will get adequate number of endpoint cases to do an analysis in terms of whether this vaccine protects against COVID-19. But what we saw is that when we were starting to enroll individuals, and this is on your left-hand side, surprisingly to us, 15% of asymptomatic volunteers at the initial start of the vaccine study tested positive for SARS-CoV-2 on PCR testing. And the majority of those individuals, in fact, remained asymptomatic. So these were asymptomatic volunteers that were being screened prior to them getting a vaccine. 15% of them were testing positive, and 2/3 of them remained asymptomatic, whereas 1/3 were pre-symptomatic. As you can see, as we moved on in terms of follow-up periods, very few cases that occurred at least 2 weeks after the second dose of the vaccine. But this was because the first wave had essentially subsided by the time individuals received a second dose of vaccine. But most striking from the study, which came as a complete surprise to everyone, was a high percentage of individuals who, when enrolled towards the latter part of the study, that tested positive on serology as evidence of past infection. So when we started the study, at the start, roughly about 10% of individuals that were being enrolled into the study were testing positive for the virus on serology. By the time we ended up enrolling the last bits of individuals, we found that between 35 to 40% of people that were randomized into the study ended up being seropositive, meaning that up to 35 to 40% of these individuals, after the first wave had passed, had already been infected by the virus in these places where this vaccine trial was being conducted. So in summary, what I've really tried to show is that we still don't have a good handle in terms of the force of infection of SARS-CoV-2 in Africa. In South Africa, based on 2 different data sets, we estimate that between 30 to 40% of people living in urban areas might have been infected. In Mombasa in Kenya, similarly, they've shown that up to 40% of people in Mombasa have probably already been infected with the virus. And these sort of serious surveys are really important for us to be able to understand exactly what impact COVID-19 has had in Africa in the absence of us being able to scale up testing by PCR. Despite a relatively modest infection mortality rate in South Africa, the actual COVID-19 mortality rate with the first wave is in the region of 60 to 90 per 100,000. And right now in the United States, the mortality rate from COVID-19 is in the region of 90 to 95 per 100,000. So South Africa has not been spared, as an example, in terms of absolute number of deaths. And this is using the excess mortality as a measure. The median age of COVID deaths in South Africa is at a much younger age than what is observed in many high-income countries, and mortality is largely being driven by high prevalence of comorbidities. These data are essential in terms of deciding who to vaccinate moving forward. South Africa is unlikely to get enough vaccine even for 10% of its population, let alone 20% of the population anytime soon. And that 10% will probably only be vaccinated after this wave has probably passed. So when vaccine does become available, we need to be clear in terms of who we're wanting to vaccinate, and our deployment strategy needs to be targeted in terms of being able to get to those high-risk groups as early as possible. And last but not least, I think we need to reflect in terms of what is the meaning of this high pass exposure to SARS-CoV-2, the type of natural immunity that probably is induced by natural infection. What is the relevance of that in the context of what is likely to be limited vaccine supply for the foreseeable future, unfortunately for South Africa and most other African countries? Thank you.
Thanks, thanks, Prof. Madi. Thanks for that data. You touched on a couple of things. Although your data was mostly based on a South African perspective, saying that the testing in South Africa is mostly about a quarter of what's been seen outside, like in the United States. You spoke about the excess mortality, and you also showed us how the infection is in Africa, particularly you related to population demographic differences in Africa. And, you spoke about the risk factors, and quite importantly, what was also said yesterday, including by the Minister of Health in South Africa, talking about the allocation criteria. And you concluded by giving us some key considerations in terms of the vaccine allocation of vaccine, who to vaccinate. And the last one was the implication post-exposure to COVID-19. Thank you very much. So we're a little bit behind time, but let me introduce the third speaker, Ms. Ricky Ishoy, who is the head of COVID-19 crisis team, the International Committee of the Red Cross. Ms. Ishoy currently leads the COVID-19 crisis team, as I've said. In a 10 years experience with ICRC, she served in many roles, including operations coordinator, deputy head of the delegation and legal advisor. She also served as a chief consultant with the Danish Red Cross, providing strategic advice on international humanitarian law, advocacy, and statutory issues. Please welcome Ms. Ricky Shaw. The platform is yours. Thank you. You've got 10 minutes, please.
Thank you very much for the opportunity to talk to you here today. True to the times that we are all living, and me also working from home, I'm having some internet problems. So I'm speaking to you from my phone. I just hope that my connection will make it through this presentation. First, I want to take a moment to appreciate the exemplary work that the African CDC has done and continues to do in terms of coordination and technical support to African Union member states, and for driving the vaccine agenda for the continent using its convening power. Recently, the African CDC and ICRC jointly organized 2 webinars on the COVID-19 response in places of detention, an example of the constructive cooperation between our 2 institutions on topics of great importance. It is also with this spirit in mind that we commit to continue our active engagement with African CDC in its effort to ensure equitable access of vaccine in the continent. In doing so, we would like to take this opportunity to bring to your attention the vulnerable segment of the population who may not receive attention in the process of allocation and distribution of vaccines. This includes the vulnerable of the vulnerable, people living in hard to reach areas, those on the move or displaced, detainees, and people in otherwise forgotten communities. We would like to draw your attention to the 29 million internally displaced people and refugees in the continent who are often excluded from basic services from the state, including health services. We also wish to highlight the 1.2 million detainees often living in overcrowded conditions with limited access to basic services. Keep in mind some of the countries affected by conflict that suffer from the breakdown of health provision or crucial health supporting infrastructure, such as water system, electricity, transportation, or communication. In addition to these constraints, lack of cold chain and storage capacity, shortage of health personnel, and travel restrictions will very likely add to the challenges of equal access to vaccines in this context. Due to the pandemic, routine immunization campaigns have also been delayed or cancelled. Health staff and humanitarian actors, frontliners are exhausted, which is impacting the capacity and resilience of essential services. Therefore, the double burden on these vulnerable populations makes it imperative to ensure inclusion of these groups both in continental and national distribution frameworks. In this case, we recognize the importance and need of a backup mechanism to catch the people who risk falling through the cracks of national vaccination activities, those living outside of government control areas, living in conflict settings, detainees, refugees, IDPs, migrants, and asylum seekers. We need to ensure an effective global COVID vaccination response, which excludes no one. Recognizing these challenges and ICSC's unique role and network, we would like to express our readiness to contribute to the distribution of the COVID-19 vaccines in areas affected by armed conflict and other situations of violence, especially in the last mile areas, such as those areas outside of government control and places of detention. ICSC contribution will also be in coordination with the efforts of National Red Cross and Red Crescent societies that together bring a community engagement and mobilizing capacity across all the 55 AU member states. We recognize the importance of community engagement and trust building to ensure local ownership through widespread dissemination of information. Community-based engagement has proven to be successful during the Ebola response in West Africa, in which timely, relevant, and actionable life-saving information was provided by putting the community at the heart of the response through our movement. In line with this, we are ready to support the African CDC in its community engagement effort in the vaccine uptake process. Beyond the continental efforts, the role of member states is pertinent in translating these objectives to reality. Therefore, we call on member states to commit to equitable access now by preparing their own national plans for distribution, including these vulnerable and marginalized segments of the population. Communicate clearly about vaccine risks and distribution plans. The Ebola experience in the DRC shows that without communities' engagement and ownership, public health response will only be partially effective. Clear communication also helps to improve safety of healthcare workers and vaccinators. States are encouraged to maintain and further strengthen routine immunization and essential health services. We need to ensure that combating this pandemic do not cause a resurgence of other preventable diseases. We call on member states to continue investment in contexts where basic health services are ruptured due to conflict and other situations of violence, and to ensure continuity of services. We would also like to underline the importance of safe access for health workers and humanitarian actors for vaccination purposes, especially in contexts of armed conflict, which should be considered in implementing vaccination plans. We look forward to working with the AU, the African CDC, and with member states in advancing the key outcomes of this event and translating them into actions that will make a real difference for people in conflict settings in the near future. Thank you very much for your attention.
Thank you very much. Unfortunately, my fellow co-moderator has got issues with the internet. So thank you, Ms. Rikisho. You know, what you touched is quite important, and you know the pledge that you made to this conference. You know, you spoke about the different vulnerable sections of our society. You know, those in areas that are hard to reach, and you know, this is the issue that was raised earlier on when you spoke about the cold chain and supply chain, so on, the detainees, the displaced people are in the conflicted areas. You spoke about and we've seen it quite a lot, where some of the immunizations had to stop due to a lockdown, or people couldn't access healthcare systems. You know, quite importantly, say this looks like a double jeopardy, particularly for the specialized groups. You spoke about your readiness to assist in terms of the delivery of the vaccines once they are available. So thank you very much, colleagues. Let me just quickly go through the questions that are on the Q&A. Maybe let me pose first one to Prof. Mali to say that, you know, quite an excellent data that you've posed on, gave it to us. The question would be, how can we get more information on COVID-19 epidemic in Africa, in the continent, so that at least we've got a knowledge of what we're looking at? And the second question would be, in line with the data that you gave us in terms of the difference or prevalence of studies in South Africa. Sorry, the question just disappeared now. Sorry, they just moved the question that I had.
I'm sorry, I answered a question online. That's the reason it moved on.
Yeah. So in line with the emerging data from the difference of prevalence studies in South Africa, what would be your recommendation for future vaccine deployment, bearing in mind the limited supply pipeline for the region? Prof. Mali, if you could please respond.
I think in terms of the first question, I fear that if we're trying to put too much emphasis in terms of PCR testing, we're simply never going to get an answer in terms of the number of people that are infectious at a point in time. And although there are other rapid tests, the antigen-based tests that are becoming available, it's got a very specific use. Right now, I think what's urgently required is for us to be able to understand exactly what happened in the past few months. And what I think needs to happen immediately is for these sort of serious surveys that are systematically undertaken, for it to be done in especially urban areas in many countries. And we're currently doing 2 in South Africa, where we'll be able to get information at a district level. And understanding what's happening in sort of smaller areas is also essential, rather than just trying to do a serious survey, which to try to extrapolate what's happening in the rest of the country. So I think the serious surveys is really the tool that we need to use to be able to quantify 2 things. The one is the force of infection that has occurred, and if countries have adequate vital registration data, to do this excess mortality sort of simulation to understand what the likely burden of COVID-19 death has been. And I think that's what I would strongly encourage be done immediately. In terms of the second question, the data from South Africa is probably not dissimilar to what is observed in other countries, in high-income countries. And I would be surprised if the same thing doesn't exist in many other African countries, in that people over the age of 65, people with hypertension, diabetes, obesity are represented disproportionately in terms of contributing to death. So when it comes to vaccine deployment, I think when thinking about what platform we're wanting to use, we can't go to the traditional route of saying that we're going to use the childhood EPI program to deploy vaccines to individuals that hardly ever have contact with those sort of facilities. So we need to think about which are the facilities that those individuals would actually go to get chronic care. And many of those individuals, unfortunately, might not even know that they're diabetic or they're hypertensive. So that adds an additional complexity. But I think a good starting point, at least, is to ensure that those facilities where individuals would usually seek chronic medication for those comorbidities, as well as type of facilities where people over the age of 65 might go for a pension payout, as an example, that is the platform that we need to try to evolve to become a tool a vehicle through which we can start deploying COVID-19 vaccines. We need to avoid trying to get quick fixes by trying to use platforms that might not necessarily be suited for us to be efficient in terms of the deployment of the vaccine.
Thank you, Prof. Yeah, thanks for that response. I know we're running a little bit late, but let me just quickly for Prof. Mfuso Bengu, there's a question to say that, you know, you spoke about the African values. So if there are those that are refusing to take a vaccine from and others are taking a vaccine, how does this fit into an African definition of personhood? If those that are refusing to take vaccine may put those that are taking vaccine at risk, or those that are not at risk. So how does this fit into a definition of personhood?
Yes, that's why I'm saying this is against, actually, it's contrary to the definition of personhood, because African personhood is grounded on the theory that I am, because we are, I am, and this can be qualified in two or three ways: interdependent, interrelated, interconnected, and solidarity is a necessity. So I feel that, and that's why in post-colonial and the other values than African personhood. So the other values which may influence people. And also we know that the other values like individualistic values are coming with modernism. So we cannot attribute that to personhood. But however, if we go, that's why I'm saying there's a need to start thinking and discussing about post-colonial values. Yes. I'll finish.
Thank you, Prof. So the last question, I know I'm a bit late, organizers, but I think for Mrs. Shoy, the question is, how can multilateral actors such as World Bank help to ensure vaccines reach the most vulnerable if providing funding? Is it okay if you have, sorry. Yeah, I think that's the question. Let me repeat it. How can multilateral actors such as World Bank help to ensure vaccines reach the most vulnerable populations? Mrs. Shaw?
Thank you very much for the questions.
Yeah,
I think there will quite simply be a need for partnerships across the board between international organizations and monetary institutions, between NGOs, faith-based organizations, to be able, first of all, to reach out and ensure that national vaccination plans reach the entire population, but also for those that are outside of national vaccination plans, that there is a buffer available that non-state actors, international institutions can tap into with the support of financial institutions, potentially to be able to reach those that might otherwise fall through the cracks of national vaccination plans. So there will be place for a very big cooperation and partnership effort.
Thank you. I know there are several questions coming through. Unfortunately, we cannot take them. However, we'll try by all means to respond to them. In the information that will be sent to different people. Let me, in closing, thank all the speakers. Prof. Mfunguzo Bengu, Prof. Shabir Madi, and Ms. Ricky Ishoy for quite a good presentations. And, we've got, just to borrow the word from Prof. Kekasi, what are lessons learned? We learned lessons about people that are likely to be infected, the mortality and morbidity that Prof. Madi presented on, and the importance of community engagement that Ms. Ishoy spoke about. And in the beginning, we spoke about the principles of Ubuntu. Thank you very much. And I will now hand over to the next moderator, who would be, if I can just get my information quickly, Professor Maurafi. Thank you very much. Apologies for being late. Thank you.
Excellent. Thank you very much. Thank you very much. Hello, everybody. I have the pleasure to co-moderate this important session 5 regarding factors that influence the acceptance of COVID-19 vaccines in our continent, Africa. My name is Professor Abdulrahman Ma'roufi. I am the director of the Institute Pasteur of Morocco, which is a National Institute of Public Health in Morocco. My background, I am physician and epidemiologist. I was the director of the Department of Public Health at the Ministry of Health for 5 years, and also director of National School of Public Health. I have the pleasure to co-moderate this session with my colleagues and friends, Professor Francine Ntomi, which is the chair and executive director of Congolese Foundation for Medical Research. Ms. Francine is the founder and chair and executive director of this foundation, important foundation for medical research in the Republic of Congo. She is also lecturer in immunology at the University of Marine Ngouabi at the Republic of Congo, and also associate professor at the University of Tübingen in Germany. Professor Francine Ntomi is also member of several scientific committees and international scientific networks in Africa. The second co-moderator that I have the pleasure also to co-moderate with her this session is Professor Heidi Larsen, which is the director of the Vaccine Confidence Project, London School of Hygiene and Tropical Medicine. Professor Larsen, are you with us?
I'm here.
Excellent.
Okay.
Professor Larsen is an anthropologist, so it's really a discipline which is very important in this topic. And she is also the director of the Vaccine Confidence Project. Professor Larsen is a professor of anthropology, of risk and decision science at the Department of Infectious Disease and Epidemiology at the London School of Hygiene and Tropical Medicine. She is also a clinical professor at the Department of Global Health at the University of Washington at Seattle, and guest also professor at the University of Antwerp at Belgium. So I think we have to start quickly by the first present. I have the pleasure to introduce the first speaker. Then my colleagues, co-moderator, will introduce the second and the third speakers. The first speaker is Dr. Raji Tajuddin, which is the head of the Division of Public Health Institute and Research at our prestigious African Disease Control and Prevention Centers. Dr. Tajuddin is doctor and we had also Master of Public Health with postgraduate qualification in pediatrics and public health. I know him as very really a strong person in the team of the Africa CDC. Please, Dr. Raji, you can start, please, your presentation.
All right. Thank you, Professor Marufi, and good afternoon, distinguished ladies and gentlemen. So thank you for the opportunity to share with you what we're doing as far as the uptake of COVID-19 vaccine on the continent is concerned. So please allow me to share my screen. So by the way of a very quick introduction, we've been talking about vaccine cut across the different pillars. Since yesterday, we talk of clinical trial, we talk of access to sufficient amount of vaccine on the continent. So of course, the third pillar of the Africa CDC vaccine strategy, as endorsed by our head of state under the leadership of President Cyril Ramaphosa, and the chairperson of African Union Commission, His Excellency Musa Faki Mahamat. The third pillar is actually looking at how do we remove barrier to vaccine uptake as far as the continent is concerned. You will agree with me that whatever we do, even if we bring all these vaccines in this world and there's no appropriate uptake, then we have not been able to achieve much. So in this regard, we needed to understand what is the perceived risk and perceived benefit of the COVID-19 vaccine as far as our community is concerned. So to actually, understand this, we decided to undertake a survey of COVID-19 vaccine perception in 15 member states cut across the 5 African Union regions. So for this presentation, I'll just share with you the key highlights from this study. And let me also say that Professor Eddie Larson is actually one of the principal investigators as far as this survey is concerned, and I'm sure she will also try and shed some light on some of these key findings. So this is just the research overview. I will not bother us much about this, so I'll go straight to some of the key findings. So the first thing here is in terms of uptake, that's vaccine confidence or readiness. It's interesting to know that close to 80% of our population are actually ready to take this COVID-19 vaccine when it does become available. And of course, this uptake vary from one part of the continent to the other. If you look at your screen, in terms of a percentage, you will see that 94% of Ethiopians are actually ready to take this vaccine when it becomes available, as against 59% in DR Congo. Then, of course, for the other remaining countries, you can see some variations. So if you try to look at this and see what is coming from Europe and America, I think relatively our continent seems to be much more ready to take up this vaccine when it does become available. When you look at those that are actually not ready, again, that's 1 in 5 actually are not ready in terms of, we are looking at hesitancy now. And there are a lot of reasons has been put forward for those who are not ready to take this vaccine. So again, the main reason for us to actually unpack this is to understand how do we tailor our messages when it comes to strategy to inform the uptake of this vaccine, because those 20% are actually important. So we needed to understand why, so that we'll be able to tailor our message as appropriate. So again, the different reasons behind not willing to take this vaccine include, for those who have seen a lot of disinformation, a lot of rumor, those people are not actually ready to take this vaccine. For people who think that the COVID-19 itself is exaggerated, so this group of people are not ready to take this vaccine. And of course, people who patronize the social media, especially our youth, the uptake within that group of people is actually low when you compare it to others. And for people who have not seen anyone with this COVID-19 vaccine, this particular group also felt that for them, as far as they are concerned, they are not ready to take up this vaccine. So in terms of tailoring our messages, I think we really need to focus on these 4 key groups, so that as much as possible, we will have maximum uptake of this vaccine on the continent. Again, this is also to further unpack the different reasons why people will not want to take the COVID-19 vaccine. So this is going to the specifics now. For some people, they don't trust that this COVID-19 vaccine will actually come and do what exactly we think is going to do. Again, these are the youths who do not trust this COVID-19 vaccine. These are a group of people who have seen a lot of rumors, on the social media, and that has actually informed why they think they will not want to take this vaccine. Of course, we still have some people who do not believe that the COVID-19 or the SARS-CoV-2 itself exists. So which tell us that we have a lot of work to do. And again, we have, though but small, significant number of people who also think that they are not even at risk of coming down with the COVID-19. So why should they bother about taking COVID-19 vaccine? Again, so all this is to inform how do we tailor our public health messaging as far as encouraging people to take up this vaccine. And last but not the least here is people who think that the way the vaccine is designed, is not designed in such a way as to protect them. So looking at the different misinformation or disinformation or rumor that is out there, because again, we needed to understand what exactly is this rumor that is going on there, so as to allow us to frame the public messaging when it comes to talking to our community or the population in general. Significant number of people, about 50%, believe that this COVID-19 is a planned event by foreign actor without necessarily mentioning countries. So 50% majority think that this COVID-19 itself is something that has been framed by the actors out there. Again, in terms of rumor, some people also believe that about 43% believe that some of our the continents will be used as guinea pig to test whether this vaccine is effective or not. And again, some people believe that the vaccine itself, the deployment of this vaccine in Africa is just to use Africa as a testing ground. And some other people believe that even the limited trial that's taking place on the continent has led to the death of several children. Again, about 25% of people believe that the spread of COVID-19 is linked to 5G. So if you unpack this, it's just to allow us to understand the different rumor that is out there so that we'll be able to appropriately tailor our messaging, appropriately communicate to the community, and to also decide who do we actually talk to in the community as far as encouraging the uptake of COVID-19 vaccine is concerned. So in terms of advocacy, so this particular slide is looking at the seal of authority. If you look at Africa CDC, we are just 4 years old. So it's interesting to know that 14% of the continent still believe that when Africa CDC say that this vaccine is safe and is effective, they are more than ready to take this vaccine. Of course, WHO has been there for long. So again, if WHO puts its seal of approval on this vaccine, 58% of the continent is ready to take this vaccine. So this particular slide underscores the need to work with the different partners so that collectively we are able to appropriately frame the messaging around them uptake of vaccine. It's also interesting to know that some of our member states or some of our populace believe that the frontline healthcare workers are also in a position of authority to tell them that, yeah, this vaccine is safe and effective. And if this information is coming from the healthcare workers, they are more than glad to take this vaccine. So this further emphasizes who are the relevant stakeholders in terms of advising the populace on the uptake of this COVID-19 vaccine. So Professor Marufi, I would like to stop here and welcome comments, questions, and reflections. Over.
Thank you very much. Thank you very much, Dr. Raji, for this important and excellent presentation. I would like just to remind our distinguished presenters really to respect the time for the presentation, maximum 10 minutes, and also to silence all cell phones that they have and mute when other speakers are presenting. I have the pleasure to send the floor to my co-moderator and colleagues, Professor Francine Ntomi, to present the second presenter. Please, Francine.
Thank you. Thank you very much, Professor Marufi. And good afternoon, everyone. And I'm very pleased to do this co-moderation with Professor Heidi and Professor Marufi. The next speaker will be Dr. Tian Johnson. So for the Vaccine Advocacy Research Group, Dr. Tian Johnson is founder and lead of the African Alliance, queer advocate and member of the Ministerial Advocacy Committee on the COVID-19 vaccine, mandated to develop a COVID-19 vaccine allocation framework for South Africa and provide recommendations to the MAC. So, Dr. Johnson, we are very happy to listen to your presentation on the role of risk communication in vaccine acceptance. The floor is yours.
Thank you so much, Prof. And what an honor to be amongst such esteemed panelists. Prof. Larson, certainly someone whose work we look up to in terms of how we respond to community issues. I'm not sure if my slides will be shared automatically, or should I share my screen? Okay, I'm being told to share the screen. I will do that. Okay, can you see my screen?
Excellent, excellent.
Wonderful, thank you. So colleagues, firstly, thank you for your generosity in awarding me that honorary doctorate. I go by Tian Johnson. I'm the founder and leader of the African Alliance. Thank you again for having us. I wanted to share with you this afternoon some reflections and thoughts on the work we have been doing in South Africa in terms of how we understand communicating risk, but also using communications as preparatory work for the rollout of a COVID-19 vaccine. So in this presentation, on behalf of the African Alliance receives support from the South African Medical Research Council and the Department of Science and Innovation. And we do this work in partnership with the Vaccine Advocacy Resource Group, which is 100% funded by activists across the globe. In today's presentation, colleagues, I wanted to touch on how we understand risk, what is our collective and individual risk in a pandemic and how we understand that. How do we deal with risk communication of a vaccine when it comes to acceptance? And how do we communicate prioritization? I think one of the first things that we come across in our community work is acknowledging the power of peers. You have communities that were shown in a previous slide, really that have not, in their minds, seen COVID. They haven't seen anyone who has died of COVID. They don't know anyone in their neighborhood who has died of COVID. So this is increasingly becoming a challenge in terms of how we as community advocates and civil society begin to communicate around individual and collective risk. We've also seen the power of the media. What am I hearing and where am I hearing it from? And of course, based on the platform on where you are hearing that content, it really comes down to integrity. Communities want to know that the platforms and the individuals that they rely on for clear evidence-based information can be trusted. So questions around trust, and do I believe them? What will drive me to act? Is it fear? Is it self-love? Is it love for others? When it comes to self-love, we've seen this approach being successful in some areas around mask usage, in that I'm wearing this mask not only for myself, but for the love of brother, sister. So the principle of Ubuntu, I am because you are. And lastly, do I want to care? And I'm going to unpack in one of the upcoming slides why this is such a pertinent and relevant question, and why COVID vaccine rollout and communications needs to happen within a context. We need to understand it within that social, political, and economic context in which it is happening. So we've been here before. We've come from decades and decades of communicating risk and what risk looks like, whether it's HIV, whether it's wearing a seatbelt, whether it's secondhand smoke. So how do we begin building trust for vaccine acceptance? We recognize firstly that vaccine rollout happens in a historical context. And that context is rooted in a historically justified mistrust of science and research. There's an inherent mistrust of science and research. And as we go forward communicating about any form of science or research, we need to be very cognizant and aware that it is within this context that our work happens. This is racialized and it is gendered. However, we've seen significant strides being made and measures put in place to ensure the safety of these vaccines. More needs to be done by researchers to bolster faith in science, and one such way is through transparency. So when we look at transparency, in our view as the African Alliance, COVID-19 has opened up science significantly more than previously. We as advocates and community leaders have had access to scientists and to research sites that we've never seen in our 10, 20 years doing this work. But there still remains an urgent need for transparency and accountability, as this directly impacts the community's trust in a potential vaccine. We've seen a trial in South Africa, for example, that has gone on national media and stated that the job of getting a COVID vaccine is a scientific one. Communities must come secondary. They're a sideshow, they're a distraction. And it's that kind of harmful messaging that puts our collective work back. So in South Africa, we still don't know what agreements have been made with regards to access to vaccines that are being researched on our continent, in our countries, at our universities, using our public funds. Communities and civil society across the globe have a right to know what agreements are being made in our name on behalf of our governments when it comes to access to COVID-19 vaccines, and this must be challenged, and it is being challenged. Civil society across the world are launching access to information applications in their courts to ensure that vaccine research happens in an accountable, community-owned and transparent way. So in terms of the context, to build on my previous comments, we work in an environment where there's denialism, there's hesitancy, and there's a significant rise in the anti-vaxxer movement. And the anti-vaxxer movement, at least how it manifests in some regions in Africa, is distinctly different from how it manifests in other areas. It is not a given that more information will counter vaccine hesitancy or increase vaccine acceptance. A lot of the times we assume that just pumping out that information will help and deal with the hesitancy issues. We know it won't. We assume that the drivers for hesitancy and denialism are lack of knowledge and that more knowledge will solve the problem. But yet we see scientists, we see senior political leaders who actively perpetuate misinformation around COVID-19 vaccines. And sometimes you find that knowing more about the subject actually increases concern. So a few things to speak about around positioning the rollout of a COVID-19 vaccine for optimal support by communities, especially knowing that not all communities will access the COVID-19 vaccine immediately. It will be staggered and there will be priority groups that we will look at for access. So we talk about how voluntary is this? Are we making it easy as possible for communities to access information, knowledge, and finally the vaccine? So do we choose to walk up the mountain or do we choose to slide down the mountain? A lot of the issues around communicating risk is about control. Who is in the driving seat of this issue? Who has control and are they trusted? Fairness. If we are all at risk, why do some have greater access to benefits than others? And perhaps you could say who has first access to a vaccine as opposed to others. In terms of the process, communities want to know, are you trustworthy? How do you present? Are you arrogant? Are you concerned? Are you empathetic? One of our struggles as civil society working in this space has been a long time call for humility in scientific research, because it is that sense of lack of humility that puts further distance between how and why the research happens and communities who need to benefit from the fruits of that research. Lastly, the issue I touched on morality. Am I wearing this mask for myself or am I wearing this mask as a result for my love for another? Familiarity. How familiar is this issue accessing a vaccine, interacting with this pandemic? Have we encountered this issue before? Childhood vaccines, yellow fever vaccinations for travel, etc. Memorability. Do we have something like this that we remember within our recent lifetime? And does that impact on how we act now in terms of seeking information, taking the responsibility for my safety and the safety of my loved ones and my community on my shoulders? So actively developing that thirst and hunger for knowledge. And lastly, dread. If you look at HIV in comparison, we saw our family members dying in front of our eyes. But now, how do we speak about risk in the context of a pandemic with an astoundingly high recovery rate and so many asymptomatic cases? I like the slide that Prof shared earlier, where it said, we don't know this thing. No one here has died of it. So how then do we approach communications in that context where there's no immediate perceived threat? One of the seminal thinkers on risk perception that this presentation is based on, Sandman, speaks about this concept of diffusion in time and space, looking at one hazard, or in this case, an illness that will affect or kill 50 people, anonymous people, over the year in a country, and a second one that would wipe out a huge neighborhood. And how then do we balance that perception of risk and urgency? I've attached a screenshot with a conversation I had with a really powerful community leader in one of the provinces in South Africa, which has been sustainably one of our largest hotspots and problem areas, the Eastern Cape. And she said to me, inequality is catching up with us. Most people who don't have hope for the future don't care about COVID-19 or passing it on to other people. So this speaks directly to the importance and the urgency of us to discuss COVID-19 vaccine acceptance and rollout in a social, political, and economic context. Do our people have hope for the future? Because if there's no hope for the future, and that means jobs, that means freedom from sexual violence, freedom from political oppression. If our people have a future to look forward to that is positive, that can directly feed in to their desire to stay alive and healthy, not only for themselves, but for their loved ones. Just yesterday, Dr. Okonjo-Iweala said, we need a communications plan. It can't be governments only. Our church leaders, our mosques, our imams. Communications is vital. Each country must have a plan and reach out to those trusted in communities to spread the word. We need our young influencers on social media to spread the word. And she really spoke to my heart, because right now our work in South Africa is looking at working with government agencies to help these agencies understand that government agencies should not be engaging directly with anti-vaxxers. We have legislative frameworks under the current national state of disaster that provides opportunities to deal with the intentional spread of misinformation. So we have to look at localizing influences with integrity from grassroots to grass tops. It's not just the celebrities, it's not just the people with 1 million followers, but it's who is your influencer in your village, on your street, in your community. And using that information to develop this multi-sectoral communication strategy that outlines the roles and responsibilities of government, researchers, and civil society that all have distinct but complementary roles in the context of anti-vaxxers, vaccine hesitancy, and vaccine denialist. So there needs to be clear parameters of communication, but most importantly, we need to feed into that work of developing this communication strategy community perspectives. So throughout the festive season, we'll be engaging with those 3 priority groups, those over 65, those with comorbidities, and healthcare and other essential workers, to really understand their perceptions, their expectations, and their hopes for when a COVID-19 vaccine arrives. So community consultations must form the basis of the COVID-19 vaccine rollout. And in the broader context, community engagement must be funded. It must be funded just as much as the rollout is funded, or else that directly jeopardizes the billions of dollars of research and investment into a product that will sit on the shelves if communities are afraid, fearful, and hesitant. Thank you, Chair.
Thank you very much, Dr. Johnson. I have now the pleasure to give the floor to the Professor Larson to introduce the third presenters. Professor Larson. Professor Larson, do you hear me?
Yes, I do. Yes, I'm happy to, there's a bit of change in roles here. So I'm very happy to introduce Dr. Gitinji Gitahi, the Group Chief Executive Officer of AMREF Health Africa, and picking up on this importance of engagement that was really stressed and really beautifully presented by Tian. She will talk on community engagement and minimum actions for COVID vaccine delivery. Thanks very much.
Hello. I hope you hear me, moderator.
We hear you.
Good. Thank you very much. I will go off video because I'm on the road and the network is unstable. But at least I wanted to, say hi, and you make sure that I am not a bot. It is me speaking. So there I am. I'll go on audio now that you confirmed on there. But thank you very much for giving me the opportunity. I am part of Africa CDC as well as a member of the governing board. And I am really impressed by the work that Africa CDC has been doing so far. And now this next step is really critical for us to work together. Now, the issue of vaccine acceptance is reminding us that vaccination programs and the efficiency is less important than the other, because vaccines don't save lives. It's actually vaccination that saves lives. Now, the willingness to be vaccinated, as you've seen from the previous presentations, is ranging anywhere between 60% to 90%, 98% I've seen for Ethiopia. But we know that actually it may be lower educational attainment. It may be lower in those who live in rural areas. Right now, I'm in a rural area where I'm looking at the communities I'm working in here, and I don't know what their take is. Actually, when you ask them about the vaccine, they're like, what is that? Because they are really, really rural. And among other groups, as I was highlighted earlier, for those who have actually already received the health system support, it on everything else we say, depending on history given, when you talk to them and when I talk to the safety of the vaccine, particularly vaccines have been developed. We've seen this in the obedience of government measures, that there is a very low trust of government. Additionally, there may be also lack of trust for medical research community and for pharmaceutical companies as well, who are actually manufacturers of these vaccines. Some people may feel they do not need the vaccine, either because they have already had COVID and they are not sure whether if I had COVID, do I need the vaccine? Or if they believe they have had it, even if they do not have a positive test. And they do not believe, some of them don't believe that COVID-19 exists or is a serious threat to their health. And some may simply not believe in vaccination. But actually, even as we reflect on this range of 60 to 90%, we must remember some countries have high acceptance. The future should be based on the lowest denominator. If I saw the graph that was presented earlier, it shows DR Congo, for example, at 59%. We must not base our based on the lowest denominator, which is the 59 differences. Then we meet. There's a group that really worries me. There's a group that says, no, we don't have the vaccine. But there's a group that says, maybe I am unsure, I may. That group is waiting for information. And we must keep that group in mind, not only the people who say no, but the group that is maybe, we must also keep it in mind. So as I come forward to kind of conclude, I must say that the WHO increasing vaccination model can be used as a good framework. And this model actually puts motivation, individual motivation, as a center, questioning what do people think and feel? What is their perceived risk? What is their worry? And also, what are the social processes that provide recommendations, social norms, gender norms, equity, information sharing, and rumors? And that motivation model then asks, are the people ready? Are they willing? Do they have the intention? And why are they hesitant? So the personal motivation, are you motivated so that, we know people are motivated for childhood vaccines because they want their child to be alive. What motivation is going to drive people to accept the COVID vaccine when actually they feel as if their own personal threat or risk is too low? So we need to look at the 3 V's, the vaccines, reflecting on the need for trials to be done within African communities. Safe, efficacious, accessible, that people feel they are so. Secondly, vaccinees. Are they motivated? And is the vaccination convenient? And third, vaccinators. Are they adequate? Are they skilled? And are they motivated to vaccinate? So in so doing, I want to suggest a few questions we need to ask ourselves by putting our minds in the minds of the people we want to vaccinate. And those questions have to do with vaccine availability in my neighborhood. Do I need to go to a health facility? Where will I be vaccinated? We need to think about those questions. Secondly, do I have to pay for the vaccine? What other costs do I bear? Transportation to the facility. Are there certain costs? Finally, convenience. Can I get the vaccine after work? Is it convenient for me? What are the queues? Do I need to bribe somebody to get this vaccine? So we need to think about these questions. So what must we do in conclusion? We must do the following things before, not after. I am detecting a lot of focus on the vaccine and planning for community readiness, and we are not doing it. We must move to community readiness before the vaccines are actually available to ask the people to come to the queue. Remember that hesitancy may also increase when the vaccine is already in the country because of anxiety. So we need to start before. Community leaders, social mobilization tactics, training and educating community health workers and other health workers, developing non-financial incentives for communities, also ensuring vaccine convenience, and remembering, as was said earlier, no one size fits all. If we do not do this, then we will waste money on vaccines, because vaccination is what is going to increase our return on investment on the vaccine. So if we do, community engagement is what is going to increase our return on investment. So we require to look at additional resources, where they are going to come from, and these significant efforts must be both at a continental, national, and a community level as well. I want to stop there, but reiterate, this needs to be before the vaccine lands in the country, not after it lands in the country. I rest there, moderator. Thank you very much, and back to you.
Thank you very much, Dr. Itashi, for this important presentation and idea that you share with us. Very important. So now I think we will move to the part of question and answers for our presenters. Thank you very much for the quality of your presentation and thought and idea important that you share with us. So we have many questions that come from the audience. Probably I will start with one question for Dr. Raji. There is one question: what about the research design, face-to-face or telephone interview? How were the respondents chosen? Another question also for Dr. Raji. It's about really will there be a mandatory COVID-19 test prior to vaccination? I think we can respond to this question after. Another question, Dr. Tazin, what strategy is Africa CDC is pursuing in our continent regarding the COVID-19 vaccine? What strategy is Africa CDC pursuing to amplify its voice and advocacy on vaccine uptake? Dr. Raji, you have the floor, please.
All right, thank you, Professor Marufi. So let me start with your first question on methodology. Of course, the time was short, so this didn't allow me to go into the details of that. But I want to assure our audience that come Thursday, that's 17th of December, 11 a.m. East African time, we will be having a press release or press briefing on this perception survey. So we invite everybody to be part of that briefing session. So having said that, just a quick summary. So this was a mixed methodology. So we had face-to-face on one side, and we have a computer-assisted interviewers by way of telephone on the other side. So it's a mixed sort of technology and a mixed methodology. And we did look at 15 member states with a minimum of 1,000, 1,000 respondents selected from each of the member states. And in terms of selection of member states, this cut across the 5 AU region. We also factor in the population of the different member states. We also factor in the COVID-19 burden. So we can share the details of this on Thursday. On whether we have a COVID-19 vaccine strategy or not. Yes, Africa CDC, African Union do have a COVID-19 vaccine strategy that has been endorsed at the highest political level. The goal of this strategy is to vaccinate a sufficient number of the populace. Here we are talking of 60 to 70%, depending on the efficacy of the vaccine that is eventually deployed on the continent. And under this strategy, we have 3 pillars. One is how do we ensure that Africa is part and parcel of development of the vaccine in terms of clinical trial. The second key pillar there is looking at how do we ensure access to the sufficient amount of this vaccine, this encapsulating like a financing and so on and so forth. The third pillar there is looking at how do we remove barrier from uptake. And this particular pillar is looking at issue of regulation, is looking at issue of delivery, and is also looking at issue of uptake. So a detailed, the detailed strategies available at the Africa CDC website. So I don't know whether there is anything I did not respond to Professor Maruvi. So let me stop there and hand over back to you. Thank you.
Thank you very much, Dr. Raji. I have other couple of questions also for Tian Johnson. The first question tells that how does civil society becomes part of the framework discussions on the agreement linked to the access of vaccines in South Africa and Africa overall? The other question also for Johnson, how you are going to manage the conspiracy and fake news about the vaccine. Some say it is the mask, it is the mark of the beast. Is it true? The floor, you have the floor, Johnson.
Thank you so much for that, Prof. I think the first question on civil society, the main message is that civil society should not wait to be invited to the table. Civil society needs to be fully aware of the politics, the power, the profiteering that go into making these decisions, specifically the access agreements. So civil society needs to rise up and take their seat at the table, the seat which is theirs by virtue of them being mandated by the communities in which they work. So that's the first thing, is for civil society to get informed, get involved, and get loud. History has taught us that if we allow the pandemic and those that make profits from our ill health to move ahead without us securing our seat at the table, we know what will happen. We've seen it with HIV. So we need to take up our rightful place at the table and ensure that decisions are made under the mantra, nothing about us without us. When it comes to addressing fake news and misinformation, I think it is critically important for us to understand the context in which this information comes up and also not to give it extra life. The more we pay attention to it and give it life, the more it will increase and be spread. So at a community level, our messaging is verify, verify, verify. Where is this information coming from? Do you know where this information is coming from? Is it coming from your Department of Health, the Medical Research Council, or a scientist with a long-standing background? In South Africa, we have a legal framework to lay a charge against anyone who willingly spreads misinformation around COVID-19. And that is important, and that is something that we laud our government for. It is a critical piece of legislation that we as civil society have to make work. Because again, the investments we are putting in this vaccine, we are only going to see those results if communities are aware, have knowledge, and are passionate about securing their life and the health of themselves and their loved ones.
Excellent, thank you very much, Jensen. I have the pleasure to give the floor to my co-moderator, Professor Francine and Professor Larsen.
So thank you very much. I disappeared because we have very unstable internet at the moment, so I do apologize deeply. So, so maybe I will ask a question to Dr. Tajidin. So how this survey has been done in Africa regarding who were the responders for this survey? Because when we look at the information, even on the news, we note that this hesitancy and the population seem not willing to be vaccinated. So you have obtained a very high proportion of individuals, about 80% of the African population. How, who were these respondents, and how do you explain that? Thank you. And
all right, thank you, Francine, for your question. Yes, so the responders were Africans, just like you and me, you know, and again, the responder also cut across the rural and the urban setting, also cut across the different age group. And the uptake or the confidence level actually vary from country to country. It's as high as 95% in Ethiopia and as low as 59% in DR Congo. So it's not something that is uniform across board. but that's exactly what the finding is. But of course, when you unpack these figures, there are a lot of a lot of information behind these figures. For instance, the older age group are much more ready to take up this vaccine than the youth. So meaning that when you're talking of your messaging, when you're talking of your strategy, we need to just have a way of engaging the youth specifically, because the hesitancy level is much higher among the youth than in the among the older people. When you also try to unpack or disaggregate along the line of whether urban or rural, uptake level is higher in the rural area than in the urban setting. Again, which means that you just need for a way to really address what is driving the hesitancy in the urban setting. So there is a lot of information behind this figure, but the general finding, the uptake level, that's the confidence level is higher in Africa compared to what we are seeing in Europe and America. Over.
Thank you very much. I don't know if the co-moderator has a question.
I think Professor Larsen, she would like to add comments. Please, Professor Larsen.
Yes, thank you. I don't have any questions. I think we don't have much time left, but one, I just want to really acknowledge and applaud the initiative that Africa CDC has taken. Also, especially in this area of understanding the public's sentiments, that's often left till too late. And it was really a lot of foresight to be doing this already. So just to thank them, and it's really important. I just wanted to reinforce the comment on hope and instilling hope, because without a motivation to live on, it's hard to be motivated. But just a couple points on the implications of the findings in the survey work. It's very clear that there's a number of areas that are very important to get in any kind of communication campaign, and that is to address who gets COVID. I remember during HIV, one of the most powerful things was when there was a whole mix of posters of people, different ages, different shapes, sizes, whatever, saying, does this look like HIV? Does this look like HIV? And I think with COVID, we really need to do a better communication of the human face of COVID, the range of ages, the range of situations that affect it. Because until people hear the stories of families and individuals who have been affected, it's going to be hard. And there are plenty of stories across the continent that can tell their stories. The other thing is there's clearly a lot of misinformation, particularly around the trials. I think getting communication out there about the global map, the fact that, Europe, the US, other countries in the world, Brazil, Indonesia, parts of Africa have all been, this has been a hugely global effort in terms of the trials. And this isn't the first vaccine that's been given recently. There have been tens of thousands of people around the world who have received these vaccines in the context of trials and have put themselves forward for the sake of others. And I think, we need to get more of that information out there. And just to, again, thank the work of particularly Dr. Raji. We've been through a lot together to get it this far, and but also to everyone. It's really an excellent contributions here. Thank you very much for being able to participate.
Thank you.
Excellent. Thank you very much, Professor Larsen, for this important inputs and really very interesting idea. I have on the list, I think, some medical question. I don't know if Dr. Raji, you can, for example, give some feedback. The question tell, for example, will there be a mandatory COVID-19 test prior to vaccination?
No. The simple answer to your question, Professor Maruvi, is no. Even the fact that you have recovered from COVID-19 vaccine does not preclude you from taking this vaccine. So because we don't know for how long the immunity from the infection is going to last. So it's advisable for each and everyone to take the vaccine. But having said that, people who have recently received any form of antibodies, be it monoclonal antibody or convalescent serum, are actually advised to wait for like 3 months before they take the vaccine. Of course, the reason is obvious. Over.
Excellent. Another question also, medical perspective. How long is the protection for the COVID-19 vaccine?
We also do not know. We don't have answer to that. So
yes.
We still monitoring, and we just hope it will last as long as possible.
Exactly. So I think the vaccine is new development. It's very difficult to judge and to define what is the period of protection, because really the period of that we have from the beginning of clinical trials is very short. I think the maximum now is 3 to 4 months. It's really difficult to establish clearly and define what is the duration of the protection of this vaccine. I would like also to participate with some, I think, other idea. This decision is very important, really, about what are, as respondents and as managers, it's very important to learn what are the drivers for uptake of vaccination and acceptance of vaccination. This is really okay factors for the success of any vaccination program and plans. I think one factors also that is really very important that influence the behavior of people is question of attitude of health professionals. I think people generally they trust on the what health workers said and what health workers do. I think it's very important to involve in the communication campaign, really the adherence and also the participation of health professionals and health workers in the motivation and in the behavior change of population regarding this question of vaccine. Other factors also that related to environment, what we call enabling factors, like for example, the accessibility, the physical accessibility for site for vaccination, for example, the time, accessibility timing, and the cost also. I think it's very important that a lot of countries announce that vaccine will be free for population. This is really a facilitating factor that could also improve the uptake of vaccine. The location also of the site should be equally very accessible also for population to facilitate access to these services. And also, I think colleagues and presenters talk really with very excellent inputs and idea about personal factors, like, for example, thoughts and feeling. I think it's very important to for motivation of the population and for this vaccine uptake, it's question to highlight what are the social benefits of vaccination, for example, for their family, their friends, and their, for example, person that are important for them. It's very important to see that this vaccine will not only protect themselves, but also will protect also their social environment against this threat and this disease. So this is really some points that I would like to share with colleagues. I don't know if Professor Francine, do you have you would like to take the floor? Professor Francine?
Oh la la. The connection.
Yes.
Bad connection, sorry. Thank you, Africa CDC.
Hello?
Oh, at the moment. Do you hear me?
Yes, yes, Professor, yes.
Okay, so I just want to thank really Africa CDC for COVID-19 vaccine and for training people and all the efforts made for the continent. So thank you so much. I don't know if you have heard me.
Yes, yes, yes. Très bien. Il y a une autre question en français qui vient de sortir. Comment pourrait-on conserver le vaccin à très basse température, notamment pour les zones rurales? I think it's question regarding the conservation of vaccines, very medical. Yeah. Très bien. Professor Larsen, do you would like to add some words at the end of the session?
No, thanks. I think I gave my overall comments and thank you. It's really been an excellent session and I really appreciate.
Excellent, excellent. So we have just 3 minutes to conclude this important session. I would like first to congratulate Africa CDC and partners for organizing this meeting, very important meeting, and particularly this session, which really regard one topic that is very important, how we can influence and how we can change behaviors of population to uptake and to accept to do vaccine against COVID-19. I would like also to congratulate and thanks really the presenters for the quality of their presentation. Really, we heard a lot of very good idea that will really help policymakers and decision makers in terms of developing and designing plans and programs for COVID-19 vaccination. I think in terms of conclusion, it's really clear that information alone in its own, it has a limited impact on facilitating and mobilizing population for vaccination uptake. I think there is a lot of factors and drivers that we have to take account in terms of moving and changing behavioral of people and the population regarding acceptance of vaccination. We have, I think, 3 kinds of drivers and factors. We have the first category of factors is related to enabling environment, which facilitate really the use of this service of vaccination. The second category is related to social influences and social norms that could also influence and determine the really the behavior and the change of behavior regarding the use and acceptance of vaccine. And the third factor is really personal factors that related to motivation of persons regarding, for example, thoughts, feelings, and it's very important to influence and to negotiate people what are the benefits, social and economic and personal benefits really behind using this vaccine as a preventive tool and preventive intervention against this risk. So again, thank you very much for this really important session. Really, I like it, very, very good idea. And I give the floor to the organizer. Thank you very much.
Thank you.
So great. Thank you, Professor Marufi. Thank you, Dr. Taj and Professor Larsen. Excellent session, really great session, and all the contributors. Let's move on to the next session, and it is my pleasure and really great honor to introduce Mr. Tidjam Cham, who serves in several capacities. First and foremost, related to this conversation, is his role as the African Union Special Envoy for COVID-19 response. So he's part of a group of envoys that were appointed by His Excellency Cyril Ramaphosa the President of South Africa, and the current chair of the African Union. TJAM Cham is, as I said, an envoy and has served in several capacities. He's currently the chairman of the Rwanda Finance Limited. In addition to this, Mr. Cham is one of the board members of the Caring Group and a member of the International Olympic Committee, as well as being a member of the Group of 30, the G30. Previously, he served as the Chief Executive of the Credit Suisse Group AG, Group Chief Executive of the Prudential, Chairman of the Association of British Insurers, a Board Director of the 21st Century Fox, Co-Chair of the World Economic Forum, and Secretary of the Development and Planning for Côte d'Ivoire. So it's truly an honor to have TJAM free some time from his extremely busy schedule to be with us. And yesterday, I think the group was so anxious to have you, TJAM, speak yesterday that they were actually requesting if you were on. And then we said, no, it's today, so that you were reserved today so that you can pull traffic from yesterday's very large attendance to today. And I think that's why we have over 240 people attending today, I'm sure, to listen to you. So without much ado, I'll turn the floor to you to move on with the session. Thank you.
Thank you. Thank you very much, John, for your introduction, your kind words, and hello to everybody on the call. I want to start with a word of thanks to the Africa CDC and to the African Union for bringing us all together today and for giving me a chance to speak. It's a privilege. It puts me in a bit of a challenging situation because I'm talking to an audience where I think every single person knows more about the topic than I do. So I attended as many of the sessions as I could, and I found them extremely informative. I want to thank all the speakers. It was very, very interesting, and for a layman like me, it was very, very helpful. The fact that actually, as a business person, I'm here talking to you, I think is an indication of a very unique character of this crisis, because we don't usually have a dialogue. I insist on the word unique. John referred us to a Lancet article yesterday, and I read it since then, and I read they say this is a global health emergency that demands a global solution. I don't think any of us would change a single word in that statement. So free to the extent possible, maybe think about some early lessons learned from all this. So going back to the context, it makes me feel old because I was on the Blair Commission in 2003, 2004, and then all the work that led to Glen Eagles. And I think that the 20 years of growth that we've enjoyed in Africa can be tied to that big push of the early 2000s for debt reductions and investment in education and health. The results have been very good. With all respect to Belgium, I have many Belgian friends, but in the 80s, a very popular statistic was that the GDP of sub-Saharan Africa is lower than that of Belgium. It was another way to tell us that we're irrelevant. Well, that GDP has gone from $600 billion to $2.5 trillion today, and that's all thanks to the work of the African people. So we were in a reasonably good situation when this shock hit us. It was a very strong African reaction led by the heads of state. John has referred to it. The Africa CDC has played a key role, the African Union, the Afreximbank, we heard them yesterday, our frontline health workers, civil society across the continent has mobilized. But we also quickly realized that we were able to do something like 2% of GDP, where many of the developed countries went to 10, 11% of GDP. So it was clear that we needed some help from outside to face this crisis, which, and it's been also emphasized by many speakers, is not quite as extensive as in other parts of the world from a health perspective. Every single death is one death too many. But that said, the numbers are still okay. What has been really very dramatic is the economic impact on Africa. And I'll come back to that, but it's been very severe, from the drop in exports or drop in government revenue, the drop in remittances, because a lot of our brothers and sisters working abroad have been among the categories the most impacted by this and the unemployment. So a series of negative shocks. So brings us to what do we need to do? And we need to say a positive word here about science, because the great news is that we have a vaccine, or we have vaccines, should I say. And I must say, I was among the pessimists, the one saying, well, we've never found a vaccine against a coronavirus so far. So I'm amazed by the progress made. CDC, Africa CDC has given us a good target, which is 60% to vaccinate several hundred millions of Africa, about 60% of the population. And that's a non-negotiable target. So the challenge for us is, first, can we pay? And that's a big challenge. I think Strive took us yesterday through the estimates, we're talking about $10 billion. There is still a funding gap. So it's not ideal to have to fund this effort with loans. We've done a lot of work, and that's ongoing, to create some fiscal space, we call it in our jargon, or some room for maneuver for the states financially. You heard about the G20 initiatives. We continue to push very hard. There was some progress at the recent G20, and the big potential win is really also with the Biden administration, that we managed to get some special drawing rights issued by the IMF up to $500 billion. That would really give us sorry, it's my French, ballon d'oxygène, an oxygen balloon to breathe and go forward. So all of you, please keep your eyes on that debate, and any lobbying you can do in that direction is important, very important for us. The other things is really overall the theme of resilience, and I'll come back to that later. How do we do this? I'm not going to tell you this, but you talked eloquently about the priorities, the need to prioritize the categories for the vaccine in every country, and how tricky that is. The one concept I'd like to pick up here is that of vulnerable groups, that in our desire to protect the frontline workers, etc., we don't forget the refugees and also the detainees, because their situation is particularly tragic. On the demand side, I learned a lot. This was one of my concerns. How do we convince people to actually get vaccinated and create trust? And that was emphasized many times, the importance of communication, but also the importance of communities. Working with communities, we saw that in Ebola, very effective, and it has to be an explicit part of the strategy. I think regulation is also key. We really need to approach this in a coordinated way, so that vaccine doesn't have to go through country by country hurdles, and not replicate the vaccine nationalism that we have observed in other parts of the world. And finally, the issue of logistics and cold chain and temperature is also very important. But I will say, make no mistake here, if we get this wrong, the penalty will be very steep. Several people have referred to the likelihood that Africans may be stopped from traveling around the world. I see this as a very real threat, and it makes this fight all the more important, so that we're not really cut not only from trade and medicine, but also from moving physically. So trying to stay in the time allotted again, and trying to think about some of the lessons from all this, even if it's early day. I think it's been a stark reminder that we all share the same planet. We all share the same space. Viruses are very rude. They don't care about status. They don't care about borders. They don't care about color. They go everywhere. The virus has no borders. And for me, it puts in perspective some of our petty disputes sometimes, and reminds everybody of the importance of working together on issues like this. For me, the second message, but here I'm preaching to a choir, is the importance of science. And I have to confess, I trained as a scientist, but really the importance for Africa to produce scientists is the ultimate answer. I mean, the whole, the eternal metaphor of giving a fish to a beggar or teaching him how to fish, it's really always better to know how to fish. So in the end, the big price, if we want truly to be in control of our destiny, is to be a contributor, an intellectual contributor. You also know the famous apocryphal remark of Stalin to the French Prime Minister about the Pope: how many divisions does he have? Today, it's how many brains do you have? It's the brains that generate the wealth, that create the resources to fight this. The value of Silicon Valley to the US, the value of the Nobel Prizes to the US is infinite. So at the root, the challenge is to educate enough brains so that we can deal with any challenge that the life throws at us, such as the coronavirus. A third remark is really, for me, a bit of a shock. It's something I knew, but it's been illustrated violently in this crisis, is that when the will is there, the money is there. We're often told when we talk that the resources are not there to help us. I mean, the scale of the effort made by the developed countries when their populations at stake, a minimum of $13 trillion. That is absolutely unprecedented, gigantic. And I think that in the future, it's a number we should not hesitate to remind people of, because it shows that where there is a will, there is a way. A lot of the terrible problems we talk about do not need $13 trillion to be solved. So if the world can mobilize $13 trillion so rapidly, this is something we just need to keep in mind and not hesitate to use when necessary. As an African, I think I'm quite proud of the way I think people have rallied around the continent. I've been with John on many of those calls with the African Set of States, on WhatsApp, on Zoom, and there's been a degree of focus on this that I don't think we would have seen a few decades ago, and that's a positive. I also think that, back to my point on communities will be key to whether we solve this rapidly. But it's also one of the key messages, I believe, from this conference. And my sixth and last point here is really this concept of resilience. Life will always throw challenges at us. I think it's very important that we make sure that our societies are as resilient as possible. And I have spent quite a bit of my life worrying about debt, restructuring debt. It would have been better not to take that debt on in the first place. So being prudent debt management, being prudent, because in the end, it's often we, the leadership, decide to borrow that money, and it's a population that pays it back. So it's very important that we just always keep those things in perspective and are prudent in making those decisions, and also that we really continue to work on making our societies more open, more transparent, and strengthen the social fabric of society, because in the end, the ultimate form of resilience is really that social fabric. That's what keeps us together. And I actually believe that that's one dimension where Africa can legitimately say that it's ahead of the rest of the world. So my final word is that really we need to continue to work as we've done. I think this was a fantastic event. I was really proud to see so many African and non-African bright brains working to deal with this in Africa. Let's turn this crisis into an opportunity for us to show the world what we as Africans are able to do. So thank you for your attention, and I will stop here. Thank you, John.
Thank you so much, Tijan. This is really great words of really encouragement, because we believe strongly that we actually need a multi-dimensional, multidisciplinary approach in solving this crisis. And your quotation and reference to the Lancet paper describes it all. I think I must say, personally, as a public health expert for the last 30 years, I've learned more, even during the last 12 months working with people like you, the Ngozi, the Vera Songwe, the Strive, Donald, more than I've worked with my public health experts. And in that, I've learned so many things there. And each time we are having those calls and you guys use some words I quickly Google to find out what does that mean, and I get enriched myself.
You do that to me too. So I Google a lot when I listen to you.
I quickly Google and then I act like I feel very proud. So this is really the Africa's moment. And I've said earlier that no one ever had promised us as a continent that it will be easy. That anything that we tackle will be easy. Those who fought for our independence didn't go into the fight thinking that it was going to be easy. And I think this is our moment, and the moment to come together as as I said earlier, using the whole of continent approach, the whole of society approach to address this generational defining moment. I mean, we feel the impact of the COVID for many, many years to come, as you, the experts in economic world, is telling us. I think I would segue to the next speaker and introduce Glenda Gray, who has been a great ally in this preparing this conference. The Medical Research Council and Africa CDC team up in a very significant way to plan for this conference as a continuation of implementing our strategic plan, which Dr. Taj did explain earlier. Just by way of background, we started these consultations way in June, and June 24th and June 25th, where President Ramaphosa, as a rotating chair of the African Union, actually chaired the first meeting where about 3,000 participants took part in. And then subsequently on August 20th, we presented it to the Bureau of the Head of States, and they endorsed the plan. And since then, we have been implementing it. I think people like Slim Karim and from South Africa and Samba Soul from Mali have been co-chairing a clinical trial lane, which most of you on this call, including Francine, are part of that. And then, of course, all of the invoices that you heard yesterday are part of the Pillar 2, which is financing acquisition. And Pillar 3 deals with preparedness and delivery. So I think it is with a lot of excitement that we continue to build the partnerships with member states, very respected organizations like the Medical Research Council, and those who have been in this struggle. They struggled in public health for decades. I think Glenda is one of them. Most recognized faces around clinical trials of HIV/AIDS and other trials on the continent. So tapping on that expertise from the Medical Research Council, working with the African Union and WHO side by side is really, and our partners outside the continent, like the London School, is really going to be the way forward. So let me invite Glenda to begin to bring us slowly to the conclusion. And then, we'll summarize and say goodbye to this, which is just one step in a series of consultations that we'll continue to have as a continent. So Glenda, please, over to you. Needless to introduce you again.
Thank you. Thank you, John. So on behalf of the African Union, the Africa CDC, as well as the South African Medical Research Council, we want to thank the participants that joined us to have a look at a framework for fair, equitable, and timely allocation of COVID-19 vaccines in Africa. We opened our session with my Minister of Health explaining the importance of a vaccine program, as well as delineating the burden of disease of COVID-19 in South Africa and in Africa. And he is an important person to help us not only get vaccines for South Africa, but to work with the rest of the region to ensure timely access to the vaccines. When we spoke these last 2 days, we brought in the African Indigenous Values System and Ubuntu in the way we would approach fair allocation of vaccines. We've heard about the challenges of rolling out the vaccine. I've seen some issues about the issues of 2 doses, the issues of cold chain storage, some of the logistics to roll out a vaccine, and also some of the issues around how resilient our health systems are and how resilient they need to be to roll out an efficacious vaccine. But we are very fortunate because 10.5 months after vaccine development started in COVID-19, we have 4 efficacious vaccines. These are early efficacy, as we've heard, and so we know their early potency, and we also know their early safety. We obviously will need to follow up these vaccines and see in the long term what the durability or efficacy is of the vaccine, and get information on long-term safety. There will be challenges in the first generation of vaccines, and we already heard about them. The issues of cold storage, -70, which means a lot of people in Africa may not be able to access -70, a vaccine that requires -70 refrigeration, just because of the infrastructure that we have. And we would have to see if we are beneficiaries of the mRNA Pfizer vaccine, how we equitably distribute a vaccine that requires such stringent cold chain monitoring. We also heard about the Moderna vaccine that has been evaluated in the US and will be rolled out in high-income countries. The EUAs for these vaccines already for the Pfizer one has been activated, and vaccine rollout is happening. And we also very soon we will hear with the EUA for the Moderna vaccine. There is another vaccine, a third vaccine, which is the AstraZeneca vaccine, which is the Chadox Oxford collaboration, and a chimp-add vaccine that has less stringent storage abilities, but also has a two-dose vaccines which require kind of bar fridge refrigeration. This vaccine is probably going to be the cheapest vaccine of the lot, and has been touted to be between $3 and $4 a dose. And so we will see whether this will be the most affordable vaccine for our situation. Over the next couple of months, we will hear more vaccines come on board, and hopefully these vaccines that we'll hear about early next year will be as efficacious as the vaccines that we saw earlier. Obviously, a one-dose vaccine is easier than a two-dose vaccine, so we have great hope for the Ad26 J&J study that hopefully we will only require a single-dose vaccine. And so I guess for the next couple of months, there will be a lot of work as we try and register or license these vaccines in our countries with the help of WHO and other regulatory authorities. We also will have to work in innovative ways with public-private partnerships to ensure that we can distribute the vaccine in ways that we've never had to distribute vaccines before. Currently, we're very used to having mass immunization campaigns, and we have very good EPI programs, but this vaccine rollout will require innovative ways of rolling it out, and we will have to think about how do we do our public-private partnerships and what are the logistics going to be. We heard Trevor Manuel told us again that Africa is on our own. We are on our own, and it's our job to make sure that we get these vaccines and that we negotiate to make sure that our continent gets them. We also heard that he stressed the need for public-private partnerships to support the rollout of vaccines in our country. Again, we know that health is a global public good, and we should all be in alignment with this. We need to resolve the logistics and we need to resolve the procurement, the logistics, and the rollout of these vaccines. But we can do this together. We don't have to wait for the perfect vaccine or the perfect dose before we roll out the vaccine. We need to learn from the vaccine rollout that is happening abroad and try and adapt it to the local area. I do believe that we will be able to work together to ensure that we can get the vaccine as quickly as possible to the people that need it in our country. And those are our frontline healthcare workers, our essential workers, they are our elderly. We also heard that elderly is not so old in Africa. We may need to start thinking that our elderly are over 60 and not over 65, or even between over 50. So we have to think about that. We have to find ways of identifying how we immunize elderly people in our communities and use innovation like pension payout queues and other places where people queue and other strategies. But we also heard in the last session was about community engagement and the issue of trust and the issue of vaccine hesitancy. And I think it's very important for us to take our communities with us and to understand the reasons for the lack of trust in vaccines and how to develop and improve on the very good knowledge that we have that vaccines are good public health interventions. And so John, it's been a great pleasure to work with your team. I have to really say thank you to Nikes and Andrea for having long conversations with us in the middle of the night to deliver this, for your support in collaborating with us. I want to say thank you to Ames and Mongezi for working very hard with me, and all the moderators and all the people that are, all the rapporteurs behind the scene that are writing as we speak, and all those people that gave us magnificent and high quality input. It truly has been great. Going forward, we will rapidly put the proceedings of this virtual workshop together to allow for distribution. And based on the discussions we've had and the questions that have come out, we will continue to have these endeavors to support our governments in the rollout of these vaccines on our continent. I'm very happy to be part of this process, and I'm very happy to collaborate with everybody to make sure that we can deliver a vaccine to Africa as quickly as possible. So John, I'm going to hand over to you. Just again, a great thank you for you and your team, for everybody who did all the translations, and for the technical team that have been working behind the scenes to make sure that everything works, and which is not not a small task in Africa, where we are troubled by bandwidth issues and electrification issues. So this is a spectacular 2 days, and I thank you for being calm and collected and making sure that the show goes on no matter what. So thank you very much, John.
Thank you, Glenda. And I mean, let me first of all thank all those who have thanked before, so that I get that out of my way. And but for you and your leadership in particular, from the Medical Research Council, I think it's one of those planning that you work across groups, but it's very stress-free. I think when we started initially, we weren't sure at the AU level how much we are going to be a problem to you with our bureaucracy, but we worked, you understood us and we understood you, and we kind of forged this together, and we look forward to moving to the next phase of implementation. So I think, colleagues, we've come to the end of this, and let me just say that, as Glenda mentioned, the report will be finalized, and we hope to partner with WHO next week to roll out the outcome of this very fruitful and impactful consultations over the last 2 days. And we'll carry that over to the next, the new year, where we will be engaging with the leadership of the African Union to specifically discuss delivery of vaccines across the continent. And so vetting this discussion one notch higher to the political leadership is where we hope we'll be going, presenting these reports to them, to ministers of health, ministers of finances, and ministers, and the head of the Bureau of the Head of State. So I think, again, thank you all, and particularly the team that worked behind the scene. From my side, Nikesh, Tash, Andrea, and everyone who supported it, and of course from the Medical Research Council side, led by Glenda. So thank you all, and bye-bye.
Bye-bye.
Bye.